Fueling the growing aspirations of its people and driven by rapid development of infrastructure, the Indian economy is accelerating its growth like never before. An inspiring reflection of India's economic progress is the burgeoning countrywide demand for modern high-end cars. Indian Oil, India's leading fuel brand, has been fronting the development of innovative products backed by its world-class R&D to meet the fast-changing needs of customers. To fuel the aspirations of the upwardly mobile car enthusiasts and to accelerate their cars' high performance, Indian Oil has led the path to bring for the first time in the country a high-performing and the best-in-class premium fuel. XP100 100-octane premium petrol. Indian Oil's XP100 premium petrol with superior anti-knock properties improves engine power with faster acceleration, enhances fuel economy and offers better drivability with increased engine life. Equally heartening is the positive impact it would make for a healthy and cleaner environment with reduced carbon emissions. Its low benzene content will drastically reduce carcinogenic emissions and its low aromatic content will reduce suspended particulate matter, thereby improving the air quality. Indian Oil's XP100 premium petrol is the first such fuel being launched in India. It is an innovative achievement of Indian Oil through intense and sustained efforts of its world-class R&D, harnessing an indigenously developed technology interface, using multiple production streams and quality systems. Adding yet another feather in the crown of Atmanirbhar Bharat, Indian Oil helps India join the League of Select Advanced Nations like Germany and the USA to offer 100-octane high-performance fuel to demanding customers across the country. Now, when you rev up your mean machine for a passionate drive, be assured that Indian Oil is backing you with a matching high-performance fuel. XP100.
When the nation joins hands to fight a common enemy, victory is certain. Though this enemy is an alien contagion, it can be no match for the fervor that unites 1.3 billion citizens. The call by the Honorable Prime Minister also mustered the power and the energy of the nation to surmount the current challenge, bringing into the fray energy conglomerate ONGC. Responding swiftly to the crisis arising from the coronavirus pandemic, ONGC started safety measures very early. Employees were asked to prepare and be technologically ready to face any restriction on movements. Work must go on was the intent. Employees who had been working on the offshore locations and onshore locations offered to continue working with extended duty periods away from their families. Our 24/7 operations and their commitment has ensured uninterrupted supply of oil and gas for the nation. They toil in the fields, adhering to all government guidelines of social distancing and hygiene. Giving additional impetus to these efforts, ONGC contributed 300 crore rupees from their CSR fund, and employees gave 2 days' salary amounting to around 16 crore rupees. But ONGC didn't stop there. We reached out to millions who suffered hardships due to the lockdown. All work centers of ONGC across the country distributed relief supplies to the needy and protective gear to frontline fighters like medical professionals, municipal workers, and security staff.
We at ONGC have always risen to the call of the hour. During this national crisis of COVID-19, we have maintained our offshore and onshore operations round the clock to maintain uninterrupted supply of oil and gas to the nation. While maintaining our operations, we have also ensured full compliance of Government of India as well as WHO guidelines like social distancing, maintaining personal hygiene, work from home, and maintaining operations with skeleton staff to contain this pandemic. I firmly believe together we will overcome this national crisis.
Individually and collectively, these humane acts reflect the selfless, committed, responsible, proactive, and energetic spirit of the nation and also of ONGC, a responsible corporate helping every Indian fight this challenge collectively.
Fueling the growing aspirations of its people and driven by rapid development of infrastructure, the Indian economy is accelerating its growth like never before. An inspiring reflection of India's economic progress is the burgeoning countrywide demand for modern high-end cars. Indian Oil, India's leading fuel brand, has been fronting the development of innovative products backed by its world-class R&D to meet the fast-changing needs of customers. To fuel the aspirations of the upwardly mobile car enthusiasts and to accelerate their cars' high performance, Indian Oil has led the path to bring for the first time in the country a high-performing and the best-in-class premium fuel. XP100 100-octane premium petrol. Indian Oil's XP100 premium petrol with superior anti-knock properties improves engine power with faster acceleration, enhances fuel economy and offers better drivability with increased engine life. Equally heartening is the positive impact it would make for a healthy and cleaner environment with reduced carbon emissions. Its low benzene content will drastically reduce carcinogenic emissions and its low aromatic content will reduce suspended particulate matter, thereby improving the air quality. Indian Oil's XP100 premium petrol is the first such fuel being launched in India. It is an innovative achievement of Indian Oil through intense and sustained efforts of its world-class R&D, harnessing an indigenously developed technology interface, using multiple production streams and quality systems. Adding yet another feather in the crown of Atmanirbhar Bharat, Indian Oil helps India join the League of Select Advanced Nations like Germany and the USA to offer 100-octane high-performance fuel to demanding customers across the country. Now, when you rev up your mean machine for a passionate drive, be assured that Indian Oil is backing you with a matching high-performance fuel. XP100.
Namaskar, good evening to everyone to this 9th Global Conclave of AEOHD, Delhi. And this conclave is for 3 days. Today is the last day, and we have already discussed lots of interesting and relevant topics in this conclave. And today we are going to discuss many of important issues pertaining to the current situation. We sincerely thank to our all participants, our speakers for joining us and make this event successful. Here I would like to request our President of AEOHD, Dr. Gajendra Kumar, to say a few words and permit us to start the session. Gajendra sir, please.
Thank you, Dr. Biplab. Good afternoon, friends. This is a privilege to welcome you all again on the third and the final day of our 9th Global OCCUCLAVE Conference 2022. For last 2 days, we were deliberating on important and relevant topics as far as occupational and environmental health is concerned. Today, we have again got a panel of excellent and very, very senior faculty people. Those will be speaking on different topics. So I welcome all the speakers. I welcome all the participants to this conclave. Thank you so much.
Thank you, sir. Thank you for welcoming our experts as well as speaker and participant, as well as permitting us to start the session.
Please.
So, dear experts and participants, today, as you know, today is the third day, and we are going to have many relevant topics, and particularly the topic few name I would like to say, like role of the wearable and telemedicine in cardiac arrhythmias, management of industrial trauma, adult vaccinations, fact and myths about the lipomas, and many other discussions. So we have many experts. So today, the first topic we are going to start is the role of wearable and telemedicine in cardiac arrhythmias. To discuss this issue, we have a Dr. Anil Saxena as an expert in this conclave. Welcome you, sir. So it is my honor and privilege to introduce Dr. Anil Saxena. He is Executive Director of Cardiac Sciences, Fortis Ascot Heart Institute. Dr. Anil Saxena is an internationally acknowledged expert in the field of cardiac pacing and electrophysiology. Since joining in the Fortis Heart Institute in 1989, Dr. Saxena has been actively involved in setting up the Department of Cardiac Electrophysiology. He is one of the pioneering in implantations of ICD and biventricular pacemaker in India, and has one of the largest experience in this field. He has been performing electrophysiological studies and radio frequency catheter ablation for various complex cardiac arrhythmias for over 25 years, with thousands of successful patients and procedures in his credit. So as you know, the cardiac arrhythmias is very important, and it is a huge cause of morbidity and mortality in the current situations. And in this meantime, the emerge of the wearable gadgets and telemedicine is also helping us to take care of these arrhythmias. So here I will not take much time. I would like to invite Dr. Anil Saxena and requesting all the participants to ask the questions end of the sessions, or you can put your questions on chat box so that we can discuss you. Sir, it's over to you.
Yeah, thank you. Thank you, Dr. Biplav. That's indeed a very generous introduction. And I will begin my talk on the role of wearables and telemedicine in cardiac arrhythmias without much delay. Now, as you pointed out very rightly, that cardiac arrhythmias is not only a common problem, but it can also be very dangerous. And it can be responsible for sudden cardiac death or stroke or very serious cardiac disability, including symptoms and cardiac failure. So the reason why these wearables have been developed is that, and telemedicine applications in cardiac arrhythmias has been developed, is because cardiac arrhythmias have a very variable course. They may not be always present when the patient visits the hospital. And these devices, they allow us to record the electrocardiogram at home when the patient is doing various activities, including during sleep. And it can transmit data through various devices via the internet to the hospital or to the healthcare providers, which can then be analyzed and interpreted and acted upon. So what are these wearable devices? Basically, this term refers to a number of devices which have been developed which have electronic chips inside them, which can record ECG, and which are somehow connected to the internet, and therefore have the ability to transfer these whatever data they collect to the healthcare providers. And this includes wristbands, it includes watches, it includes some other add-on devices. And the essential component is that they have some method to record ECG. And there are two ways to record ECG, which I will come to subsequently. This is a white paper that was published last year by the Heart Rhythm Society on clinical utilization of digital health technology. And you can see that it lists a number of devices which can record heart rate and electrocardiogram, and they can be utilized for the clinical care. So how do wearables detect electrogram? One of the common early development was the use of photoplethysmography. And even cell phones, when they have a camera and they have a photo source. Whenever a device is placed next to the human skin and a light is emitted by the device which illuminates the tissue underneath, and then there is a camera which can detect the phasic changes in the blood circulation, and these changes can be converted to a waveform, and this waveform can be then subsequently used to detect the RR intervals, and it correlates very well with the electrocardiogram. So this was the earliest way how these were the heart rate was detected. And still many devices are based on the photoplethysmography, including the early iterations of Apple Watch, Apple iPhone, and there are so many other devices, particularly phones, which utilize this technology for detecting the heart rate. Then there are some ECG based devices which are even more accurate, and which include various new watches, including new Apple Watch. It includes Alive Core Cardia, which is now very commonly used and very popular, where you have a small device like this which connects to the smartphone, and you can actually stick it to the smartphone also, and you just have to place 2 fingers on the device and it will record ECG for 30 seconds, which can be converted to a PDF format and then sent to the doctor. And it also has a built-in software to detect arrhythmia, so it can tell us whether the rhythm is normal or it has atrial fibrillations. It is approved by US FDA for diagnosis of atrial fibrillation. And similarly, Apple Watch is now very commonly used, at least in USA. It is expensive, so that's a concern, but it records ECG beautifully. And not only ECG, it has so many other parameters that can record. It can record oxygen saturation, it can record tachycardias, bradycardias, fall detection is possible, and the respiratory rate, and sleep pattern. So it can record a number of human parameters, and it's very useful for overall assessment of health. Then there are so many other devices which are coming up. For example, there are textile integrated wearable devices which are built into a t-shirt and which can record ECG. Then of course wristbands are there, and standalone phone, ring, etc. A lot of devices can be utilized which are available in the home and workplaces, which can collect health data from individuals and send it. Now, what is digital health and telecardiology or telemedicine? They are all interconnected. Wearables, digital health, telemedicine, they are all interconnected. But specifically, telemedicine refers to utilization of remote services for providing healthcare, for diagnostic and healthcare services. And this was not possible earlier, even though the technology existed, but it was not approved by the government. So there was a regulatory issue that doctors could be pulled up for providing telephonic advice or video advice without examining the patient. But last year, with the onset of pandemic, the government of India launched that document. It's a very comprehensive and beautiful document on telemedicine, which defines what all is possible, and it sets up the boundaries which all the physicians must respect as to what can be done with the telemedicine, what cannot be done. But it's something which is very useful for our country because we have a huge landmass with poor infrastructure. The doctors, particularly the specialists, are not available in very remote areas, and the technology has become very affordable. Telecom has become very affordable, And this has been a positive outcome of the pandemic, that everybody has got used to utilizing these video conferencing tools and Zoom and video meetings. And also it has become very easy for even less educated patients to access doctors in best hospitals through telemedicine. So that has really revolutionized the at least the consultative process, as we can say. So that slide again shows how a patient sitting in his home can transmit data and access the physician sitting across thousands of miles. And in the same way, a physician sitting in his office can access patients from very remote locations, and they may be from any state or anywhere, thousands and hundreds of miles away, and they can be seen one after the other sitting in his clinic, and they can look at the data, they can talk to the patient in real time and answer the questions. And it's very useful, especially in two situations. One is the specialist consultation, and second is in the follow-up care. Similarly, the devices like pacemakers and defibrillators, they can be monitored from remote locations. This has been done for a long time, but it's become even more common now. And many patients with pacemakers and devices who could not come for follow-up, they opted for remote care in the pandemic. And they can now be monitored sitting at home. There is a tripartite agreement between the hospital, physician, and the manufacturer and the patient. And they can provide this remote care utilizing a specialized equipment which the patient may have to invest in. And the new devices, they are Bluetooth enabled. So by using the smartphone, patients can monitor their pacemakers and defibrillators, etc. So telecardiology services in India, there are many barriers, particularly the patient awareness and the choice, physician awareness and choice. Some physicians and patients, they find it not the best thing. So they still prefer in-person consultation, but can be utilized as a complement to the in-person visits. There could be some technological and logistic challenges and economic issues with certain patients, but it offers huge opportunities to a large number of our patients sitting in remote areas where good hospitals or very experienced specialists are not available. As far as the evidence pool is concerned, I will not discuss in great detail, but some studies are very popular and commonly known, like, for example, the Apple Heart study, which was done on over 400,000 patients without atrial fibrillation, who were given Apple Watch, and they were monitored. And about 0.5% patients, they gave notification of irregular pulse. And it was a very good correlation with the actual atrial fibrillation. And this just shows how the older patients, they got more notifications, and they also had higher incidence of atrial fibrillation compared to the younger individuals. Another study, which is Hawaii Watch study or MAFA2 study, that again was done on a large number of patients. And it also showed that the diagnosis of atrial fibrillation was very good by utilizing this remote monitoring technique, utilizing the screening part and then confirmation, and then patients were they were enrolled in the integrated care pathway. And this shows how the transmissions were in the early part of the study. Most of the patients were diagnosed early on, and they were subsequently confirmed. 87% had AF confirmed, and then they entered the integrated care program. Another study, which is Fitbit Heart study, is underway. So this technology can be used particularly for monitoring of atrial fibrillation and other cardiac arrhythmias, including ventricular premature beats after treatment, which may sometimes be asymptomatic but can have important implications. Like, for example, we know that atrial fibrillation patients can have stroke, and the other patient, the VPC patient, may have sudden cardiac death. So it offers something for everybody. For the patient, there is a benefit in remote monitoring and telecare, and for the doctors also, it is really very effective. And now with increasing accuracy, it is getting more and more popular. So it can be used for not only for diagnostics and disease management, it can be used for medication adherence. It can be used for clinical research, for symptoms and environmental data collection. It can be utilized for education. The digital health applications can be utilized for research and education. And also there are so many apps which can help with the lifestyle modification by looking at the sleep pattern, by the activity pattern more objectively, and telling the patient constantly that you have to improve. So these are direct to consumer product. Many of them they're not even manufactured by medical companies. They first they are sold to the people, and then medical studies may be done on them. So that's what they call them wearable. They're basically consumer facing devices. So what does the future look like? This is the data over last few years, and we can see the publications of telemedicine research. They are rising constantly in last 15-20 years. And this basically the right panel shows various elements of digital health, where you have components of digital health, health equity, diverse discipline. I will not go into, because this will take a long time to explain. But digital health today has the ability to transform the health and well-being of people who have high risk and who have a lot of chronic conditions, where digital health can monitor various parameters and help the patients and physicians. But there are certain challenges. For example, the acceptance of any new thing is not easy. So for patients to accept that this is the new normal, this is the way medicine is going to be practiced in future, many patients found it very difficult to believe that doctor can give advice without putting the stethoscope on me or checking my pulse in real time. That's a common thing that every doctor does: check the pulse, look at the tongue, look at does some examination, push the stethoscope on chest. And patients find it very difficult that this can be done by teleconsultation, but gradually it is changing and patients are accepting it. Same way for the clinician also. So virtual visits are becoming more common, and many patients now we advise them to come once in 6 months or 1 year, but we tell them to get various tests done periodically and do a video consultation so that we can talk to them, look at the symptoms, look at various reports, and advise them how to change their medicine. So I come to the last couple of slides. The key points about wearable devices are that these are technologies which primarily consumer facing devices, which utilize either ECG or photoplethysmography in diagnosing cardiac arrhythmias. These devices are very good for screening, for detection, and for monitoring arrhythmias. And we can take various decisions, especially in atrial fibrillation. The rate control, rhythm control, and anticoagulation decisions can be taken by use of these devices. But we need to have a lot of studies, which are, some of them are ongoing, but we need a lot of studies to examine the utility of these devices and how they can be applied more and more for management of various cardiac arrhythmias. Similarly, telemedicine is a very rapidly growing segment of healthcare, and teleconsultations, remote monitoring of patients is being increasingly done by utilizing telemedicine. It's very useful for India because specialists are not available in remote places, but they can be consulted. The best people can be consulted by using online platform today. So it's something, a completely new paradigm of healthcare, which encompasses a number of technology like computers, electronic databases, connectivity, and wearable devices, which can not only record and transmit data, but maintain a patient's entire digital profile, which you call a digital phenotype. And this is really changing the way we do medical research and education, also train our young physicians, and we can offer a broader base with the help of technology. So I think I will stop here. This is something very new and very fascinating to me as well. So I'll be happy if there is any question, I'll be very happy to answer. Thank you so much for listening.
Thank you, Dr. Saxena, for enlightening us about the new technologies. And here I would like to invite any comment, any questions regarding this topic. Of course, I have a couple of questions which I will ask after some time. So participants are requested to
I got a question.
Yeah, sir, please.
Sir, this technology is about, in India, it is about 15 to 20 years old. Even I worked in railway hospital, and long back, 10 years back, 2011, I was medical director in railway hospital, Jaipur. There we started this telemedicine system. So what we did, we installed the ports in the zonal hospital at Jaipur, and connected it to the small health unit like Fulera, like Degana, small places. And we started. Now the problem arose when there is a need for consultation. The specialist is either in the OT or in ICU. So he's not available for consultation. The patient in the health unit, the far end, is continuously sitting with the doctor waiting, and there is no reply. Then that time we realized we need dedicated people to take care of telemedicine. The regular doctors, those are working in OPDs, clinics, OTs, ICUs, they cannot take care of this extra load of telemedicine. This is one. So your comments on that. And then second important question is, suppose a patient is being treated with telemedical system. Patient is in a health unit. The health unit doctor is transmitting his vitals and data to a general hospital specialist doctor. And specialist doctor is giving the treatment. Now, during the course of treatment, some eventuality happens. Under CPA, who will be held responsible? Is it the specialist or is it the treating doctor? Or if there is a failure of the link and something goes wrong with the patient, then will the people responsible for avoiding maintaining the internet connection will also be involved? So these are my two questions.
I think both are very relevant. Regarding the first question, it is the responsibility of any specialist who wants to offer telemedicine services that he has to commit certain time, and he
Right.
needs to honor the consultations. Of course, emergency consultations may not be possible, because we also in our like, for example, I have 3 days OPD, 3 days cath lab, so we are busy during our procedure days. But we have certain committed time, and whatever appointments we give, we try to honor them. And if one is not able to honor, one can tell the patient, okay, I will we can delay it by 1 or 2 hours. That's possible. Like OPD consultations also, sometimes patients have to wait for some time if the physician is unavailable. So once in a while it can happen, but it has to be, and once it comes in the natural practice, everybody will start honoring these OPD appointments.
Thanks.
The second part is very, very important, because as I told during in my talk also, that till last year, till 2 years back, there was no government guideline available on telemedicine. And the government of India put forth a paper in March 2020, I think, just after the onset of pandemic. Although it was in preparation, though it is a very comprehensive document, so it must have been in preparation and consultation for 1 or 2 years, which defines how telemedicine should be done, what all records are to be maintained. There has to be a disclaimer and a consent by the patient. A primary doctor has to be involved in the care and be responsible, and so the liability has to be reduced, otherwise this will not happen. So once we agree that this is something very good for our country, we have to see what are the boundaries of telemedicine, and which need to be respected, and there should be boundaries of liability also. Otherwise nobody will practice telemedicine, and the patients will not be benefited. So this has to be understood by the regulators also, by the medical councils and the consumer courts also, that if you penalize doctors who are providing remote care unnecessarily, the whole project will fail. So I think, but it will take a couple of years to stabilize things, I think.
Thank you, sir. Thank you.
Thank you, sir, for addressing this. Actually, I also have the similar kind of questions, but here my another questions will be like the gadgets, which is evolving over the period of time. And like in USA, we have a FDA. Like in India, what are the legal aspects? What are the policy related of any wearable gadgets on which the physician is going to depend? And suppose if it is not working properly, or if it is giving some like false positive or false negative conclusions, then how it is going to taken care as per these regulations by the government of India? And
Yes.
Is there any agency to take care of this, or it is entirely the depending upon the patient and physician?
I think very important question. Now, when a medical equipment company like the ICD company or pacemaker company or drug companies, they manufacture a new product, it has to be first passed through the trials, and then trial data is submitted to the DCGI, and it is approved, and only then doctors are supposed to prescribe it. But these wearables are consumer-facing devices, which means that they are often manufactured by companies which are not even medical companies, like Apple or Huawei or all. They are manufacturing watches and wristband like Fitbit, and which are sold to the consumers and not having any approval by FDA or by, they do it later on for the sake of giving more credibility to it. But for selling, they don't require it. And that is causing some confusion also, because a lot of these things are detecting arrhythmia which don't exist. And many
Yes, false negative and false positive rates are quite high.
Coming to us and calling us that, doctor, my heart rate dropped to 29, or but for 1 second flashes 29. And that happens with with these oximetry machines. Everybody in their home has a oximeter, pulse oximeter. And for 1 second, if the pulse rate drops to 29 or 36, or it crosses 130, 140, they call the doctor. The doctor, this is what has happened. So all these devices, they do have fallacies, which increase the anxiety of patients and unnecessarily cause confusion sometimes. So a lot of work, I think it's a work in progress. And as time passes by, they will become better and better. And we will learn how to deal with these issues.
Yeah. Thank you very much, sir. But I am sure that the Apple, particularly this arrhythmia and other things in USA, it is part of the legal process. They have, since they already have a FDA approval.
Absolutely.
So doctors can rely on the report given by the Apple Watch of the your ECG or your arrhythmias.
True. Apple Watch ECG is quite good, actually.
Yeah. Thank you. So thank you very much, sir, for enlightening us about this new and relevant topic, because all of us, we have to update ourselves along with the new technologies available and new technology invented over the period of time. And we sincerely thanks from all the member of AEOHD Delhi, as well as from the participant. We would like to say you thank you, sir. Thank you.
Thank you.
Namaskar. So here we are going to move on our second sessions. Our second sessions here, I would like to hand over the Dr. Kamla Fatiyal. Madam, so please.
Thank you, Dr. Biplab. Good afternoon, everyone. Today, on the final day of this OCCUCLAVE conference, we will be addressing the topic of industrial trauma. So, as we all know, management of industrial trauma, industrial injuries is a major problem, where despite the presence of safety engineers, improved working conditions which have been achieved since several decades, the government has brought in a lot of safety laws. And in this regard, we have the OSAS, where the occupational health and safety assessment is an international standard which has been kept for occupational health and safety management system in most of the organizations. In this regard, now we have a learned speaker from Indraprastha Apollo Hospital. It is my honor and proud privilege to introduce Dr. Yatinder Kharbanda, Senior Orthopedic Consultant and Joint Replacement Surgeon from Indraprastha Apollo Hospitals. Dr. Kharbanda he is specialized in orthopedics and joint replacement surgery, including revision surgery. He is a life member of Trauma Society of India and has given lectures on the subject of trauma surgery in various national and international conferences. He is an instructor of primary trauma course and has conducted about 12 such courses all over India. This course teaches a physician how to approach and treat a trauma victim systemically. I'm sure we'll find this topic very important, which is a very important topic. It will be found very useful to each one of us. Now I request Dr. Kharbanda to please take over, sir.
Thank you, Dr. Kamala, and thank you for the invitation. Let me just share the screen now.
Yes, sir. And I request all the panelists and the participants to put your questions on the chat box, and so that Dr. Saab can address the questions at the end of the conference.
It's not
The end
sharing.
of his talk, sorry.
Okay, so can you see now?
Yes, Dr. Sam, we can.
Right. So I'll talk about management of limb trauma. I mean, limb trauma is a part of general trauma that happens with any um, in any industry. You know, whether it's a road traffic accident or a fall from height, or in the factories, burns. All these things are considered as limb trauma, and the treatment is basically the initial treatment is the same, and that is the saving the life, and that is airway, breathing, and circulation. So of course, I'll talk on that also, but I'll put my main emphasis would be on limb trauma. That is my specialty. So, and most of these limb traumas are open fractures, which means that there is a soft tissue injury also. So, in a limb, there would be bone injury as well as soft tissue injury. There could be a vascular injury, there could be a nerve injury. You know, this is only in the limbs. In addition, there could be injury to the abdominal organs. There could be a chest injury, there could be a um, uh, neurological injury. So all this comprises of a trauma, and limb trauma is a subset of trauma. That is why I said that the first thing, whenever person comes to you with the trauma, you don't know what has happened, where all the trauma has happened. So you have to start with the even if there is a bleeding limb, you have to start with first airway, and then you concentrate on the breathing, and then you concentrate on the circulation, and then you come back to the whole body. Once you've made sure that the airway, breathing, and circulation is all right, then only you come back to the limb trauma or any other trauma, because this is the one which is going to kill him. The airway will kill him or her, breathing will kill him or her, and the next is circulation will kill. So one should always remember to first do the basic, that is the life support, and that is ABC: airway, breathing, and circulation. So um, coming to fractures, um, open fracture is defined as a break in the skin and the underlying tissues, and there's a communication between the fracture and the exterior, and that is the environment. So basically, it is different from a closed fracture. So terminology should be closed fracture or open fracture. There is no terminology like a compound fracture in our orthopedic dictionary. Compound is used by a lot of doctors as well as by a lot of laymen, indicating that it is a bad fracture. Now, it could be a comminuted fracture, it could be a fracture with wounds. So if you are conveying this to an orthopedic surgeon, they would not know what you are meaning. So the definition, the fractures are basically simple fracture and open fractures. Simple is where there is no wound, because the treatment is it can be very simple, because there's no chances of, there are less chances of infection, and you can use various implants that we normally use. But when it's an open fracture, it's a different ball game. It may involve a lot of surgeries, it may involve a lot of time, it may involve a lot of expense, and it can cause late disability also. So always say either simple or open fracture. Now, if fracture has to be defined, whether it is plain clean breaks or something like a non-comminuted or comminuted, that is basically going into the details of the fracture. So that is what first thing I wanted to point out, is that one should always use open or simple, or open or closed fracture. So this is an open fracture, and you can see that there is a injury to the, obviously there is an injury to the bone, skin. There could be an injury to the artery, there could be an injury to the veins, there could be an injury to the nerves also. But that has to be examined, and that is what we do when we have finished with the airway, breathing, and circulation. When we have made sure that the patient is stable, from these points, then we concentrate on our limb trauma. And that is when we see the wound, we see the deformity, we see the color of the limb, we see its circulation, we see the neurological thing. If the patient is unconscious due to head injury and or intubated, then all we can do is see for the circulation. That one has to be sure, because circulation can kill the limb in few hours. And whereas the neurological injury, even if it is missed or even not missed really, but if you can't ascertain the neurological injury immediately, then it can be it can always be taken care of it later on. That's not an emergency. So generally these fractures are like associated with a lot of comminution. So this is what is a comminuted fracture. And on the left is the fracture which is comminuted fracture of the upper end tibia, and the one which is on the right is the lower end of the femur. What are the consequences of open fracture? So when the patient comes, he's fallen, or he comes to you as a primary physician, it is very important to know whether there is bacterial contamination. So if there's a lot of dust, if it is road traffic accident, you may find a lot of dust. You may find small pieces of stones and dirt and all those things in the wound. So the important thing is to clean that, and you can clean it with a plain and simple water also. You don't need a saline or anything, more sterile thing. Just cleaning, washing with water is enough. There is also a lot of crushing and stripping and devascularization of the soft tissue. So one should not do too much of rubbing and these kind of things to cause more damage. And third thing is we have to think about is the fixation, and that's more challenging. So I'll just take you, how do you treat this? What are the goals in treatment, and how do you treat these fractures? Important goals are control of infection, because they are open fractures, they are contaminated. We have to get our soft tissues back. We have to heal the bone, and we have to avoid any malunion and shortening. And we have to also institute early joint motion. Now, this is how we go in this order. Unless we control the infection, nothing can be done. The second, third, and fourth, fifth points cannot be achieved. And prognosis depends upon how much is the bacterial contamination. So how much dirty is the wound? How much is the soft tissue devitalization? Delay in starting treatment. That is when the primary physician comes into the picture. Of course, before that, when does the patient present? But generally, patient would present to a primary physician, like in peripheries, quite early, as soon as the fracture has, as soon as the trauma has occurred. So, but delay will cause infection. Infection will cause a lot of complications. And also it depends upon type of initial treatment. I'll show in some of the illustration cases how the initial treatment has resulted into a very bad situation. So we classify the fracture in three. Basically, it's 1, 2, and 3. Depends upon the wound, level of contamination, whether the soft tissue injury is minimal or moderate or severe, and how is the bone. This is grade 1, where it's a very simple open fracture. There's a wound which is less than 1 centimeter, and there is no contamination. So we treat this as almost like a simple closed fracture. This is grade 2, where there is more than 1 centimeter of wound, and there is some amount of soft tissue injury, but they can be covered. The bone can be covered. See, important thing is to get the cover of the bone as early as possible. This is third, grade 3A. Again, 3 is divided into A, B, and C. This is again, you can see the bone projecting out, the femur bone, and again here the soft tissues, we can do skin grafting and things like that and cover the wound quite well. Grade 3B is where we can't cover the wound. You can see on the right, the bone is, after we have done the debridement and fixing with the fixator, the bone is still uncovered. So this patient will need soft tissue coverage like flaps. And grade 3C is when there is this when there is a vascular injury. And this patient ended up in an amputation because there was a very bad vascular injury. Completely, his tibia, you can't even see. His tibia was completely crushed and his soft tissues were again damaged very badly. And there's one more limb trauma that you may come across in your industries, like an industrial trauma, and that's a amputation, complete, either the finger or the wrist or the forearm or the arm. So here the important thing is that these patients should be referred to appropriate hospital as soon as possible. Before doing that, one should find the amputated part and they should accompany the patient. Many times, what has happened is the patient has come and we ask them where is the limb, and they say, oh, we forgot the limb. This happens in a hurry and in a lot of uh, stress. So both the patient and the amputated limb should be transported together. They should be wrapped in a moist, clean cloth. You need not have it can be a handkerchief. Just moist it, squeeze the water out of it, and wrap it in that, and then put it in a plastic bag. And one should not um, uh, get the ice in contact with the or cold bath, and it will destroy the tissues. So it should be kept cool, but not frozen. So as I said, keep the limb cold, do not freeze it, and one should remain calm and find the coldest thing that is nearby. Water is good enough. Okay. So coming to the initial emergency management in the hospital. Now you can do this emergency management even in your hospitals. Obviously, your hospital is equipped with all these things, but maybe for more orthopedic treatment, you may have to refer. But initial treatment, as I said, ABC, always, get airway breathing circulation completely secured. Then you assess your limb, the circulation, neurological status, examination of the wound, apply dressing. You don't have to start doing dressings like with betadine and start. Just apply for the initial management, just a clean dressing, and then you can send the person to the appropriate hospital or your own theater. And in the theater, you do everything. Broad spectrum antibiotics should be started, and clinical photographs should always be taken. This is for both purposes, education, as well as to show to the patient, and if there is a problem of litigation later on. X-rays should always be done before they are referred. So principles are that irrigation and first is the irrigation and debridement, then the vascular repair in grade 3 injuries, stabilization of the fracture, soft tissue coverage, and then the further surgeries to reconstruct the bone, to get the joints rehabilitated and various other things. So it's a very long treatment and expensive also. Irrigation consists of removal of foreign materials, removal of non-viable tissues, and that will reduce the bacterial contamination. We always say that solution to pollution is dilution. So copious irrigation, and orthopedic surgeons somehow are notorious that whenever they go to any theaters where they are called to see the open fracture, they will, the whole of the floor would be, waterlogged, because we use a lot of fluids. We use something like 10 to 15 liters of saline just for irrigation. Next is method of stabilization. You may have seen a lot of methods which consist of internal fixation, external fixation. These are two methods which are used mostly, but sometimes we may have to resort to old skeletal traction and plaster immobilization also. So in a simple fracture wound like this, which is not which does not have much of contamination, I would still put like for a closed fracture after debridement, a nail, like you can see on this side, internal fixation. Why we don't put internal fixation in bad open fractures, grade 2, grade 3? Because a foreign material always can cause further infection inside the bone. And therefore, we let the contamination and soft tissues to settle down, and then we do definitive treatment. This is in type 2, grade 2, where again the contamination is not bad, and if the patient presents to you very early without infection, then you can do, even in such fractures, a plating. Now, both these things I would not do in grade 2 who have presented to me late, or grade 3 A, B, and C. So like this is a grade 3A, and here there was a lot of contamination. He presented to us, I think, about 48 hours later, and this is how we had put an external fixation and then did a soft tissue coverage. So once you have debrided and you've done the fracture stabilization, now comes wound management. And wound management, one should always take a help of plastic surgeon, unless an orthopedic surgeon is very competent to do it. Initially, we always leave the wounds open. We don't stitch it up, otherwise we cause more damage. And you should also not. Many times, patients come to us even on day one. All they have got is wound stitched and splint. I would only give one message. You can do a wound dressing with a sterile gauze. You can splint it, but never stitch it, because stitching will cause more damage to the skin and the soft tissues. And second is, it'll keep all the contaminants inside, and they will, bacteria will just proliferate and cause further damage. It may even cause compartment syndrome. I mean, we have also got patients with compartment syndrome who got the wound stitched. So here, sometimes we just do simple wounds like this. We just close it after thorough debridement after 48 hours. Wounds like this, we just skin graft it all the way. This patient had actually degloving, which you can't see. I mean, but his degloving was there from knee onwards. You can see the knee, the skin is loose there up till the iliac crest. So he had all the way skin grafting. And these type of wounds, grade 3B, where the bones are also, I mean, there's a combination of bone, we do a flap. This is a rotational flap we have taken from the back, and this is a microvascular flap which is taken from some other part of the body, like this is a latissimus dorsi flap. And sometimes we let it heal with a secondary intention, and here the plate has been put inside. There was a small wound. We let the wound heal. We don't stitch it up, because stitching would mean tension on the wound, on the skin edges, and that can cause necrosis. Antibiotics are very important here. Role of antibiotics is to kill the bacteria, but it is not a substitute for debridement. A good debridement is always beneficial. Antibiotics should be given IV for at least 2 weeks. And if there's no infection in the bone, or if the patient comes to you with infection of the bone, then only you can continue for longer time, 4 or 6 weeks. It should be broad spectrum, but later on, if the infection comes up, and if you grow some cultures, organisms in the culture medium, then you should give it according to the culture medium. So I'll just show you last 3 cases, and then I'll close this. So this is a patient whom I showed you earlier. This is grade 3B. There's no vascular injury, so it's not grade 3C, but very bad. You can see the bone is crushed. Like here, you can see that the tibia is crushed. The skin is hardly there. The muscles have been crushed, and this is the X-ray. So our first thing was, on the left, you can see it was debrided and external fixator was put. And the second, on the right side, you can see is a flap has been done, a microvascular flap, because there was no other rotational flap. There was no any chance of doing a rotational flap. This is a flap, and then comes my bone reconstruction. That's the third thing. And here we found that there was a bone which was there was a cavity there, so I had to do a bone grafting. Now this was relatively very simple. You can see here He was walking with a fixator. So we make them walk with a fixator. The fixator remains for almost 6 to 9 months till the bone heals completely. He can do all his movements, like, knee movements, ankle movements, and eventually you can see on the right that the bone has healed completely. So this was relatively a very, I would not say very complicated, but it involved plastic surgeons. It involved a lot of, patients on both the doctors as well as the patient's part. But it was not a very complicated. The most complicated ones are these ones who have. So this is the second illustration where this 31-year-old male came to us almost, I think, 8 months after the multiple fractures. So multiple fractures healed, but his one fracture, that is this tibia, which was, they had put a nail, did not heal, and it was non-union with loosening of the implant with infection. You can see here on the right that there is a bone defect. I mean, there is a non-union, as well as there's a bone which is exposed. So there's a soft tissue defect also. So he had a necrotic bone on the medial side. Ankle movements were 10 to 20 degrees, and he also had a nerve palsy. So we had various management options. Three issues were there: soft tissue defect, second infection, dead bone, and dead space management, and third is non-union. That means we have to remove the implant, we have to do debridement, we have to put fixator, followed by healing of the bone. So there was, obviously, this was one of the very complicated cases, and to address all the issues in one go was a bone transport surgery. That means remove the implants, debride, and sequestrectomy. Sequestrectomy means, obviously, remove all the bone which is dead. One should not worry about how much bone you are removing, because if you don't remove the infection, as I told you, you can't go on second and third and fourth step. So we remove the bone. We manage the dead space with vacuum dressing, which is nowadays a boon to us. We put a PICC line, which remains for 6 weeks. We give IV antibiotics based on culture reports, and we apply the circular frame and do it bone transport. This is what we did. You can see here, we removed the bone, whatever was dead. We partly closed the wound and applied VAC, and then the frame was applied like this. You can see here on the left and the right, the defect in the bone that we created. Now, this was almost 2 inches. So now if we dock it, there would be a shortening of the limb. So what we do is we cut at the proximal tibia, that's called as proximal osteotomy, and we transport the whole bone down. You can see here, this is the fixator. After 2 weeks, the wounds had almost healed. And you can see on the left, there's on the proximal side, I'll just show you with the arrow here. This is what we had done. So whole of this bone from here to here, we had transported it down. And so gradually we transported and we docked the lower side, and the osteotomy site here, the bone forms because we only gradually distract it for 1 millimeter a day, and that produces bone there. We had to do one more bone grafting, and eventually you can see here that this bone has formed well. This bone also is consolidating, and once we were sure that the bone has healed well, we removed the fixator. This took 9 months, and eventually at you can see here at 8 months he was almost healed. And he met me actually 3-4 days ago, walking, absolutely jogging. He was even said that I've started walking and I'm now and he's now planning to start jogging. So very complicated surgeries. And last case I'll show you again of a femur, lower end femur here. This is a patient who had this sinuses also, and he was hardly able to walk. You can see that he was not able to weight bear on this, and we had to, he was walking just hobbling like this because the bone had not healed. There was infection and it was deformed. He had a lateral popliteal nerve palsy. His knee was stiff. Now there were so many issues here. Um, that was a CT scan. So plan was again the same thing as before, and we sort of divided this part here. I'll just show you. We divided this part here, divided here, we docked it, and we did a osteotomy higher up here. Uh, that was his wound after some time, and this was a special fixator we had used. It's called a hexapod, and we had started distracting from here only. So eventually, this formed the bone here. You can see that, and that is how he healed in a almost correct position. So deformity was corrected, and he still had some knee was stiff still, and his lateral popliteal nerve had not yet recovered, which many times doesn't recover, but he was able to walk at least, and he did not have a deformity. So end result was this, and so sometimes, so these are my cases which I illustrated, but sometimes we have to plan on day one whether this limb should be amputated or salvaged. And these are the cases where, there is a scoring system for us. And if we find that it is going beyond salvage, then we amputate on the day one. So in summary, open fractures are challenging, trauma. You need a team approach, plastic surgeons, vascular surgeons, and if the trauma includes chest as well as head and other things, then you involve general surgeons. And so basically a team approach. It's always, you should always treat the life-threatening condition first. Debridement should always be under anesthesia. Just washing the wound and referring the patient after 2-3 days is not good. Never suture the wound at first debridement. Thorough debridement of wound and stabilization of fracture is the key in the first stage. You give broad IV antibiotics, and then once you have controlled the contamination, infection, stabilization, soft tissue and bony reconstruction to follow further. But many times these things are not, when they are not done well, or sometimes the injury is very bad, they do end up in the last two cases that I showed you. We see those cases quite a bit, and it requires a lot of patience on patient's part and our part uh, to get it right. But there are ways. I mean, we have had quite good results. I think more than 90% we are able to get them back to at least some good good function. 10% may end up in amputations. Thank you very much.
Thank you, Doctor, for a wonderful presentation. And I'm sure everyone would have learned a lot about how to handle this lower limb trauma in each of their institutions. So I now request our president, Dr. Gajendra Kumar sir, who has a question. Dr. Gajendra sir.
First of all, I congratulate Dr. Yatendra for such a wonderful presentation and making so many things clear to us. Because such injuries are very common in the industries, and we are facing a lot of such cases. Now, sir, I got two questions with you. My first question is, up to what level of these industrial injuries or these fractures can we manage at a primary health center, that is the center into the factory or into the fields? And from what level onward we must refer it to a higher center? This is question one. And my second question is, sir, what is the time limit for getting a totally amputated part to fix it again? In what time frame it should come to the hospital? These are my two questions.
So the first question is that which trauma can be handled? See, of course, the initial injury you have to handle, because the people who are on site, and that is why I've been doing, along with my other colleagues in Apollo, and we also go outside to do this primary trauma course where we teach them to, how to deal with a victim of trauma. So ABC, we teach all everything. So we have a workshop, and I think we have done even for NHPC and
Yes, sir.
other corporates also.
Right.
So that is initial treatment has to be done at primary center. Now, second thing is, most of the trauma, which is simple trauma, like fracture femur, fracture tibia, fracture radius ulna, can be dealt. Simple means closed fractures, can be dealt by an orthopedic surgeon. They are all trained at your place. So as long as you have the facility of theaters, good theaters, which you have, it can be. I mean, the only places is far away places, in the peripheries where you may not be able to, but then they can be referred to the, your centers which have all these facilities. The fractures which are really need our this thing are the ones which are, I showed you grade 3 A, B, C type, where vascular trauma injuries are there. They should be referred immediately, either by air ambulance or by, I mean, I've done vascular injury. I've saved the legs and the arms up to 18 hours. 18 hours with a vascular injury, we have saved, and the patient has been walking and everything. So it should be done as early as possible once you have identified vascular. Rest, you can give it within, once you've done the debridement, and once you have stabilized, you can even do it up to 48 hours.
Okay.
Sending to a big referral center where you think he may need a plastic surgery intervention, more complicated surgeries, more complicated fixations. The ones that I showed you, the last two cases, although they are under my care, they came under my care, but I still ask one of my consultant, Dr. Yashwant, who has been trained in this thing. I mean, he is absolutely fabulous in this thing, and I would say that if I had such a fracture, I would go to him. But he's the one. So basically, even I'm trained, but the level of training now has increased so much, and there are so much things that you can do where more younger surgeons are doing, or more people who are trained in this. So people who are trained, if you feel that they can be referred up to 48 hours, 72 hours also, as long as you have taken care of the initial bit.
Finish.
Even the debridement part. Debridement means don't have to do debridement, but good washing and starting IV antibiotics, sterile coverage, and putting a splint. Don't worry about neurological. If there's a neurological injury, don't worry. But vascular injury has to be done within as early as possible. The
Right, sir.
second thing about amputated legs. Now that depends upon a lot of factors. One is, what is the weather like? If it's winters, the amputated limb can survive more. But in
Okay.
summers, thick of heat, it will decay very fast. So what we say is, and then second thing, it is dependent on where the amputation is. So a finger, just a finger, where there's not much of muscles in this, it can survive 12 hours.
Okay.
Whereas a forearm, it can survive only maybe 6 hours. Upper arm, maybe 4 hours. So because there's a lot of muscle and they decay very fast, even in a best of weather. So generally 12 hours for the fingers, and something like 6 hours for the wrist, 4 hours for the, I would say, for the forearm and upper arm. Leg, we don't try to put it back.
Okay.
We only put the upper limbs back. Leg we don't, because we've got a good processes, and in leg the most important thing is walking and sensation. And with the best of microvascular surgery also, the sensation would only come back to 50% in the upper limb or the lower limb. Lower limb even less. So there we have a problem. So lower limb we don't reconstruct.
Right. Thank you,
but
sir.
but as long as you save it in a cool water, not in direct contact, means what you have to wrap is, you have to wrap the amputated limb in a soft cloth which is damp. Put it in, so whole thing should be put in a plastic, seal that plastic, and that plastic thing should be put in another plastic which has a cool water. So there's no direct contact of the amputated part with either water or ice also. If you don't have to use ice. So a lot of people start looking for ice and they waste time. So just ordinary tap
Cool
water.
water.
Tap water is good enough, and then send it along with the patient as early as possible.
Right, sir. Thank you.
Thank you very much, Doctor. I think if there are any more questions, if anyone wants to ask, you can please unmute yourself and ask your question. I don't find any questions, so I thank Dr. Kharbanda for your valuable time, sir, and for this lecture. And now I hand over. I think there is a question, sir. 1 second. Should we wash the amputated part?
See, if
Dr.
there is a lot of
Sushma is
dirt,
asking.
if there's a lot of dirt on the amputated part, yes, you should just wash it, clean it, dry it, and then wrap it in a damp cloth. Otherwise, there's no need. Like many times, fingers are cut on the machines, and there's nothing in the factory which is dirty. There's no mud or anything there. So that should be just cleaned. You can even clean it with a damp cloth also, and just wrap it with that.
Thank you, Doctor. Now I hand over to Dr. Sriniket Mishra. Doctor.
Thank you, Dr. Kamla.
Thank you, sir.
Good evening, everyone. So the topic for next session is adult vaccination, and the speaker is Dr. Ishika Das. She is a senior medical advisor, vaccines, working with Abbott India Limited. Dr. Ishika is a highly professional and talented medical professional with more than 5 years of experience in developing and implementing medical strategies, as well as providing medical expertise and advice related to therapeutic and including related products and current research. She did her MBBS in 2012 from High Tech Medical College and Hospital, Utkal University, Bhubaneswar, and did her internship with SSKM and IPGMER, Kolkata, during 2013-14. She has experience in providing effective medical support related to different therapeutic areas, as well as familiar with clinical trial procedures, marketing concepts, and local regulations or guidance related to clinical research. So on behalf of AEOHD, I welcome Dr. Ishika Das to start his presentation. Dr. Das, the presentation time is 20 minutes, then we will have 10 minutes of question answer session. So please start your presentation.
Good evening, everyone, and thank you so much for giving me this opportunity. Thank you, Dr. Mishra, for such a nice introduction, and it is my pleasure to be a part of this team here to talk about adult vaccination in India. So I'll just share my screen, and if you could kindly confirm it if it is visible.
Yes, visible.
Visible? Yes. Am I clearly audible also?
Yeah.
Right. So thank you so much. And today we're going to talk on a very important topic, which is adult immunization. And I think in the current times, all of us have become quite aware that immunization or vaccination is not just a topic for the pediatric ward people only. When we think about vaccination, we're thinking about our own kids. But now we have to come to understand that immunization is a preventive measure, and it is not something which is to be associated with age only. It is for everybody, and that's where adult immunization also plays a huge part, especially in a country like India, where prevention is better than cure is the absolute mantra that needs to be followed, and especially in the group that we are discussing today. So we understand that corporates and industries, they also spend a lot when it comes to disease management or medical expenses in the form of insurances, or absenteeism because of various diseases, etc. And all that can be prevented very strongly with the aid of adult immunization. So immunization is one of the most beneficial and cost-effective disease prevention measures, while it is quite established when it comes to the children or the pediatric population with vaccination, government programs being there, I'm very sure each of us have gotten our kids vaccinated, and also our schools are asking for vaccination certificates at the time of admission. So there's a lot of checkpoints when it comes to compliance or the need for vaccination in the pediatric population. But in the same time, adult immunization is neglected and underpublicized issue in India. So it's like, if I were to ask in a pre-COVID scenario, and if you were to answer very honestly, how many of us as an adult took any vaccine, except probably the normal tetanus toxoid because of some injuries, but otherwise probably none of us are used to taking the vaccine after we have crossed the age of 18 years of age. While adult vaccination needs to be given its due course, because first it helps to boost the protection that we have received from the vaccine that we received as a child. So not all vaccines provide long term or lifetime immunity, and that's where we need to boost those vaccinations to ensure that we get protection for a lifetime. Also, to aid any kind of comorbidities that we keep getting. So India is one of the highest burdens when it comes to whether we're talking about diabetes or contributions to chronic obstructive pulmonary diseases or other non-communicable diseases. So India, because of its population size and lifestyle changes, etc., is quite a population with comorbidities, and that's also where we need to aid our immunity to ensure that we do not have further complications because of these existing comorbidities. And of course, protection and prevention. So this is protection and prevention not just from the disease, but also in terms of affordability. Once we are getting vaccinated, we ensure our expenditures range from something like 500 600 rupees to probably 10,000 rupees also if I take the most expensive vaccine in the market. But the minimum cost that is spent on hospitalization because of a complication of a disease that could have been prevented doesn't begin at such a low price point, and it is only multifolds higher. So the rationale for adult vaccination, or at least basic needs that we need to focus upon when we're talking about adult vaccination, is that there's an epidemiological shift. What has happened is, now the pediatric population, since they have been getting vaccinated against all the major diseases, there's now the disease which were earlier part of only the pediatric population are now seeing a prevalence in the adult population. For example, pertussis, or what we call as the whooping cough. These diseases are now being seen at an adult population time, and we have all taken the diphtheria vaccine as a pediatric population only and not as an adult. Similarly, we see a trend for hepatitis A also and other diseases as well. So it is not just that once we have taken a vaccine as a child, we continue to stay protected. And also because since we have taken a vaccine as a child, we are probably at a higher risk now because of the changing disease dynamics, that as an adult we may get the same disease. Another very strong example is herpes zoster. We all know chickenpox. So chickenpox as a child is not as dangerous, but if you're getting chickenpox as an adult and for the first time in the form of herpes zoster, it can be quite a serious ailment. And also traditional childhood programs over the world have been transitioning towards child and adolescent. So if you look at the population where our vaccine cards are, they're majorly towards till the age of 2 years. And now more and more when we are visiting our pediatricians, we can know that the vaccination goes up to nearly 10 years of age. And also the programs globally, including India, they are now maturing. Certain states have now included vaccination against pneumococcal, against HPV, against influenza in their vaccination programs. So it's a natural step towards ensuring immunization and protection in the adult population. So pediatric, adult, adolescent, and the older age group. So it's a vaccine for all concept that is being driven forward now. I think the current challenge that we recently had when it came to the current pandemic also that we suffered, we have all waited very strongly for the vaccine. But similarly, we had a lot of questions, and these were because most countries and most times when we have heard about vaccine in adults, it's for a high risk group or for special population only. Including the NTAGI, which is a group for advisory for vaccinations, they do not have a clear mandate or recommendation when it comes to adult vaccinations beyond the universal immunization program. Also, when it comes to adult immunization, and since all of you are from the industry, you would already know that health is a state subject when it comes to adult immunization, and we require policies at the level of state as well as at industry levels to ensure a larger dissemination of immunization, where we see a huge compromise. So except for the current COVID times, where we had to mandatory get vaccinations to return to work and other things, but similarly we have had prior epidemics with influenza also, and sometimes outbreaks of typhoid happen in our settings. But the choice of prevention of vaccination is something that we don't get as a first recall, and also this is because of the lack of data. So if you ask me today that what is the data in terms of vaccination coverage, or how many companies are giving, or what has been the changes, etc., mostly what I will have is in the terms of Western world, and the later data limitations when it comes to India is a big challenge. Now, this is a study which was done in AIMS Jodhpur when it comes to immunization. So they opened a adult immunization clinic, and this showed a very interesting find that even for immunization, which is a preventive measure, so it has to be proactive and not reactive. But even then, we saw a higher uptake when it comes to receiving of TT or anti-rabies, which is post-exposure. That is when somebody has already got an injury or there's a bite. But instead, this should have been in case of the pre-exposure category, for example for hepatitis B or for pneumococcal or for typhoid or for influenza, where we see the uptake being very low, as little as 1%, 5%, etc. So still now, even for an immunization perspective, vaccination in the adult segment is seen more of as a post-exposure rather than a preventive or a proactive approach. Now, as I began my talk, I was talking about the burden of non-communicable diseases in India. uh, this is a global picture when we're talking about the non-communicable diseases, and we've all heard of all the listed ones. Diabetes, India is the world capital. When it comes to lung diseases, we are having an increasing amount of COPD, industrial diseases because of exposure to asbestos and other materials. Stroke is increasing because of lifestyle diseases, weight issues, obesity, eating habits, etc. And heart diseases is also extremely coming up. And all of this are precursor factors for any infectious disease to be further complicated. And that is why somebody who has any of the comorbidities, they are always at a higher risk of complication for any disease. And if you would also recall from the current pandemic that we just came through, people who had comorbidities were always considered at a higher risk of getting hospitalized, and that's what something we even saw as a trend happening. So when it comes to vaccine recommendations, we have the Center for Disease Control, that is the CDC, which is a US body and which is accepted worldwide, that talks about the various vaccines that can be given in various age groups. So whether it be the influenza vaccine or the Tdap, so it would be not just tetanus, but it would be a combination of tetanus, diphtheria, and pertussis. There's also the need for MMR in cases, which something we never usually talk about. There's zoster recombinant vaccine, HPV vaccination, pneumococcal vaccination, hepatitis A, hepatitis B. Meningococcal is very relevant when it comes to people staying in army, people getting trained in army or big industrial areas where people are resident and the spaces are narrowed. So that's where we can get an outbreak of meningococcal disease, which has a very, very high fatality rate. So similarly, it also for different conditions, very specific conditions also, that's where vaccines are separately advised. For example, in case of pregnancy, in case of people who are immunocompromised, such as with HIV infections or who have undergone a splenectomy, renal diseases, people in dialysis, or because of alcoholism, heart lung diseases, chronic liver diseases, diabetes. These are all immunocompromised states. So that is where a person is naturally at a lower level to handle the disease that they're getting infected with, and hence the chances of further complication, hospitalization, and probably long-term morbidity, or what we say long-term effects of the disease persist. So looking at certain important vaccines, which are from the perspective of India, in terms of priority vaccines that we may look forward, is one of them would be the pneumococcal conjugate vaccine. And one dose of pneumococcal conjugate vaccine in the valency of 13 is advised for older adults above the age of 65 years and who have not received a dose of either the polysaccharide 23 valent or 1 year after the PCV 13, or at least 5 years. So I would rather use this graph to help you understand this. So a pneumococcal naive person, somebody who has not received the vaccine and is above the age of 65 years, should receive a polysaccharide, a conjugate vaccine of the valency of 13 at the age of 65, followed by at least with a gap of 1 year to receive a polysaccharide of a 23 valency. Person who has previously received a 23 valent polysaccharide vaccine at age of above 65 can then receive another PCV 13 because, and the rationale behind this is that a polysaccharide vaccine does not give you long-term protection. You need a conjugate vaccine for a long-term protection, but a polysaccharide vaccine ensures a quick protection. So getting a polysaccharide vaccine in the quick one go and then boosting it with a conjugate vaccine is one of the best ways to go about it if you're looking at a quick protection as well as a long-term protection. So this is the ways in which you can look at a polysaccharide or a conjugate vaccine when it comes to prevention of pneumonia. So certain facts that I would want to share with you in terms of pneumonia is that community acquired pneumonia burden is one of the highest contributors when it comes to hospitalization in India. And when it comes to treatment of or management of pneumonia, this is an unfortunate fact that the antibiotic resistance is a huge menace in our country, where even the topmost antibiotics, which is about, for example, colostins or your carbapenems, etc., even we see a very high amount of resistance, especially for Klebsiella pneumoniae and the other causes of pneumonia, or any viral disease which is further picking up a nosocomial infection because of hospital stay and leading to pneumonia and further complicating the process of treatment. So in all this, we can have a very simplified approach if we go for vaccination to ensure that we do not complicate an already complicated situation. Another is your Tdap vaccination. This is in two types: a full dose diphtheria and a small dose diphtheria. So a full dose diphtheria is till the age of 10 years. So that can be given to a maximum of 10 years of age, and up to that's when we are looking at that up to 9 years of age. One, if the child is getting a full dose, it is good enough. But after a full 9 years of age, a small d or a smaller dose of diphtheria is to be given. But it is no more a TT vaccination schedule that we must follow. It's more of a Tdap schedule, and a Tdap schedule can be offered to anybody in the gap of 10 years. And this is especially relevant for doctors who are working in settings because we are continuously exposed to various antigens around us, and that has a continuous attack on us when it comes to immunity and protection. Now, certain risk when we're talking about influenza as a disease. Now, certain categories of people are at a higher risk of serious influenza complications. So, which include pregnant women, children in the age of 5 years, and people above the age of 65 years. People with conditions of chronic medical diseases such as chronic liver disease, chronic renal disease, diabetes, hypertension, obesity, etc., or any kind of neurological diseases are at a higher risk. People living in nursing homes or long-term care facilities, healthcare workers, people who are obese, people who are on salicylic treatment for long or aspirin, and of course people with weakened immune system who have undergone a transplant or under immunosuppressive therapy or have HIV or any other infections. So when it comes to the incidence of influenza, if you look at the global incidence, it's around 3 to 5 million cases per annum, with around 250,000 to 6 lakh deaths annually. And in India, up from the years of 2010 to 2017, over 1 lakh cases and 8,000 deaths were reported. And this is data is to be taken with a pinch of salt, is because influenza diagnosis is dependent on PCR. Now, before the COVID era, there were very, very limited centers for in diagnosis of influenza. So mostly it was treated as influenza-like illnesses, and we had very less reports when it comes to confirmed influenza disease. And they were mostly treated as a complicated scenario for influenza-like diseases. When it comes to the epidemiology, so this is spread very normally, like your person to person via large droplets, aerosol transmission, exposure to fomites, and there are seasonalities which we see in our country, that there's a higher increase in the influenza circulation pre-monsoon. So any regions, we understand India has different monsoon seasons throughout the country for different regions. So we see a peak pre-monsoon. So probably some parts of India, it would be a peak in the SH or the southern hemisphere seasonality. So let us not confuse southern hemisphere and northern hemisphere with geographical regions here. These are more of seasons. So a monsoon season of April, May, June, July, August is something what is referred to as southern hemisphere seasonality, and October, November, December, January, February is a seasonality referred to as northern hemisphere. So it has nothing to do with location of India in the northern or southern hemisphere. These are seasonalities when you're talking about influenza disease circulation. And after the disease onset, which is after 5 to 7 days of exposure, the total duration of the disease can last up to 14 days and 10 days after the onset in children, and they still remain infective till a 1 week after the disease is cured. When it comes to the episodes of hospitalization, and this is because of the data of LRTs or low respiratory tract deaths in India, so you can see the episodes are quite high in the country, with hospitalization also ranging in the range of around 6 lakhs annually. And the thought that is there also when it comes to influenza is that it is a disease of the Western world, but unfortunately that is not true. India has quite a high incidence if you're comparing it with a developed country. It's around 1011.6 incidences per 1 lakh population. So the incidence numbers is quite comparable to a burden across in any developed country, where we think about influenza as a more serious disease compared to what we see in India. So it is not the common cough and cold. It is quite something, and I think it would be easier understood if we refer to it as swine flu or bird flu. But they're all varieties, but they're all part of the same influenza disease, which gets extremely complicated at times. So certain areas where the concept of NCDs or the non-communicable diseases burden and influenza meet parts is that people with diabetes are 3 times more likely to be hospitalized than others with influenza. Risk of heart attack increases by 5 times, and more likely in 3 days of diagnosis of systemic respiratory infection if it is because of influenza. Risk of stroke is 3 times more likely in days following the diagnosis of respiratory infection. So there is the direct connect between the reason as to why this is still not established, but lots of studies have been done, as you can see, which have been quoted as sources, and I can share it on request, that there is a clear um, relation that gets established between diabetes and influenza, heart attack and influenza, stroke and influenza. And of course, even in case of lung diseases, we see an exacerbation in case of chronic obstructive pulmonary diseases, where the case fatality rate goes up to 30% or more. So as I was saying that influenza immunization, if you go for a vaccine, what is the benefit? So we have seen there is a 28% reduction in the all-cause deaths in diabetic population, with 79% reduction in hospital admissions, 50% reduction in heart attack consequences, 24% reduction in stroke, and lung diseases also. There's a significant reduction in exacerbation in patients with asthma or any other obstructive pulmonary diseases. So as I was talking about COPD and asthma, so 50% reduction in hospitalization can be seen in all cause death, and 53% reduction in pneumonia, so which is one of the biggest complications when it comes to influenza, and 56% reduction in any kind of respiratory illnesses. So if you would see, if any one of you have taken the influenza vaccine in the current year or the prior years, you would have probably noticed that generally also the amount of well-being that we experience post-vaccination is better. The amount of episodes of general cough and cold also reduces, while general cough and cold is because of adenovirus, but in general our quality of life sees an improvement with influenza vaccination. And this recommendation comes for annual vaccination from all endorsing bodies such as CDC. You have the Global Initiative for Asthma, Global Initiative for Chronic Obstructive Pulmonary Disease, whether it be the European Society of Cardiology, American Diabetes Association, ASIP, ACP, RIP in India, Ministry of Family and Health Welfare, RSSDI. All these bodies individually talk about need for influenza vaccination in all the at-risk categories for a better prevention and prevention of any kind of, for the complication of any kind of infective diseases. Now, moving from influenza, another disease that we can talk about is typhoid. Uh, all of us eat out, and none of us can be 100% sure of the source of the food we are consuming, because with that habit of Swiggy or in an industrial facility where cooking is done on mass, that's where a chance of a typhoid outbreak becomes a challenge. And every year, about 26 million cases of typhoid fever and 5 million cases of paratyphoid fever occur worldwide, causing around again 2 lakh plus cases of death. And the prevalence of laboratory confirmed is about 9.7%. So again, if you know, and I'm sure all of you are aware of, it becomes a challenge to even diagnose typhoid given the timing that we have to be correct when we are prescribing a Vidal test to get the choice of, if you're getting a typhoid fever or not. Mostly, we know that somebody who has been suffering from excessive diarrhea, vomiting, has jaundice. We start the medication still. So this data again could be many much fold higher because the medication is started without a lab confirmation. Now, etiology wise, I'm just reiterating for the discussion here that Salmonella typhi or Salmonella typhoid, which is the causative organism for typhoid, is spread through 4 F's: flies, fingers, feces, and fomites. And the occurrence is more common in the South Central Asia, where India is a part. And typhoid fever is more prevalent in the temperate and the tropical countries like ours. When it comes to the impact on the company productivity, so whether we are a company where we have many people working and eating and dining and in the company premises, or we are a hospitality industry, fever becomes a risk of contagion within companies. So there are two things: it can be an external threat, it can be an internal threat. So because of the external threat, if there's the news spreads out, it leads to a damage to the company reputation. And the internal threat is in terms of absenteeism and medical cost that is mostly borne by the organization themselves. So the labor cost goes up, the productivity losses are high, the replacement cost is high, treatment cost is of course high, and the disease control cost to ensure complete sanitization and to ensure identify the source of infection for typhoid also becomes quite a challenge. And this can be prevented with just one vaccine, which gives more or less a lifetime protection if you're going for a typhoid vaccination with a conjugate vaccine for protection. Now, all of this discussion doesn't lead to fruitful execution or compliance because of one major challenge that we face across, which is vaccine hesitancy in the adult space. So we are all aware that yes, vaccines should be taken. There are certain diseases vaccines are useful when it comes to prevention space, but still there is a low uptake rate contributing to the disease paradox. And that's because there's a doubt about vaccine benefits, whether it is safe, whether it will really prevent the disease, will I still get the disease, etc. And I'll try and answer that very quickly here, that no vaccine can be 100% effective. But the population that does get protected is definitely on a higher end. And if you're weighing the benefit of vaccination to a situation of a placebo where we're not taking a vaccination is a definite winner. Uncertainty about cost benefit effectiveness, this is usually in case of mass vaccinations from an industry point of view, that if I did rather pay for the medical costs for treatment or labor costs replacement or absenteeism rather than go for mass vaccination of my entire population. uh, I can just share a study in the terms of health economic outcome research that we have conducted for our brands. For a simple influenza vaccine that can cost for a bulk purchase of around 700 to 800 rupees, the saving that we actually have for individual person is at the range of 4,500. So even the economic benefit is actually there when it comes to cost effectiveness for vaccination. Safety concerns, most vaccines undergo, in fact all vaccines undergo rigorous safety testings through phase 1, phase 2, phase 3, phase 4 trials, and which is true for all medicines, not only vaccines or any kind of medical science. Nothing is 100% safe, so we cannot say there is zero side effects or there are zero complications. But the population which experiences extremely severe adverse events is one in millions, and others are usually very minor adverse events in the form of site pain or pain at the site of injection, redness, a fever for a couple of days, and nothing more than that. There are a lot of anti-vaccine voices in our media sources now are extremely there to talk about how vaccines are not good, but let us all be pro science there. And we still have a little bit of compromise in terms of political commitment or campaigns or access to vaccination in the adult space in the same way as there it's in the pediatric space. So I'll just end my talk today saying that let's just remember hashtag vaccines for all, and that adult vaccination is a domain where each one of us need to put forward our feet and ensure that we're going for a prevention approach rather than a reactive approach. Thank you all for your patient hearing, and I'm open to questions now. Thank you.
Thank you, Dr. Ishika. Very nice presentation, very well explained the importance and benefits of adult vaccination. So we all know the benefits of vaccination. So many diseases have been eradicated, like smallpox, polio, by the vaccination. But the awareness on this adult vaccination is very low in India. We have a childhood universal immunization program by the government of India, and every state is following that. But there is no focus or awareness on this adult vaccination. So we should have a universal adult vaccination program also, in my view. And as a industrial physicians and corporate physician, we should spread the awareness about this adult vaccination in organizations also. So this will benefit the employees and their family members. Also, we can promote this influenza vaccination and all the adult vaccination in the organizations, either through the company, through the insurance, or we can provide discount at the discounted rate directly from the vaccine companies. So in my organization, we have been doing this. Like we provide influenza vaccination every year. And also our canteen workers are given typhoid vaccination every year as per schedule. So these things we are doing, but we need more awareness on this. And this also prevent this untimely deaths in the adult population who are having comorbidities. Like you said, the pneumococcal vaccines and level 65 should be there. So I think this is a very good topic, and you have very well explained all the benefits. So now the forum is open for questions and answers.
Thank you, Dr. Mishra. And I am truly happy that your organization is going for influenza and typhoid vaccination. And it would be a pleasure if you would share, from your experience, the benefits of such a vaccination scheme being prevalent in an organization, because that voice sharing is what is very important when it comes to awareness. Maybe we are all aware, but we do not have the conviction to implement, or the rationale, how do we go about with the administration in our organizations?
Yes, so this is beneficial to the organizations also, because there have been few incidents in which our employees had an untimely death due to swine flu, 2-3 cases in the last 5 years. And there has been some hospitalizations also. So if all the people are vaccinated, then there will be less hospitalization, less treatment cost. Mediclaim ratio will also come down. So these all are the benefits as an organization we have sickness absenteeism come ho jayega, there are many benefits. So I think investing in this vaccination program for the employees is beneficial for the company also. Not only health of the employees, but the productivity पे भी बहुत असर पड़ता है इसका, काफी फायदा होता है इसका. So
thank you so much.
So any questions?
Yes.
Yes, Dr. Vedant Kumar.
First of all, I congratulate Dr. Ishika Das for such a wonderful presentation. You have made so many points clear to us regarding adult vaccination. See, all of us are aware that since the first vaccine was introduced in this world 400 years ago by Dr. Edward Jenner, we all know the benefit of vaccination. Unfortunately, in our country, the universal immunization program for children is very well running, and we could be able to control a lot of communicable diseases among the children. As far as the adult vaccination program is concerned, benefits we all know, and it is implementable as well. But I fail to understand why there is not any structured immunization program for the adults, especially as far as this typhoid vaccine is concerned. I work in railways. So we introduce in the railways that all the food handlers, whether they are cooks, waiters, the people serving into the kitchens or the stations or trains, handling the food, all food handlers must undergo typhoid vaccination compulsorily every year. But now today you have made that even a single shot is sufficient for whole time. If it is so, then it will be a great advantage. And because typhoid is always through food handlers. They don't, first of all, these food handlers are not well educated. They are low paid staff. Their own personal hygiene is always compromised. So they easily, can spread the disease. As far as this immunization against influenza and pneumococcal vaccine are concerned, I want to one question to you. See, whenever in any organization these vaccination programs are introduced, it is only the top management, they come and get the vaccination. While these are the people, those are at least risk. While the workers, the workforce, those are maximum exposed to the dust and other environmental factors for the influenza and this
Pneumococcal.
yes, pneumococcal infection. They are always left out. So can you highlight how it can be changed? What should we do?
So, Dr. Kumar, this is a very interesting question, and this is true. We also see a similar trend, and that's because certain diseases come with a certain perception. So, when it comes to influenza and pneumococcal, somehow since they're confused with lifestyle diseases, so people think that they're associated with people who have more of a sedentary life. And they have a burden of diabetes and other comorbidities or hypertension, which is usually not seen in people who are more mobile or who are working in the industry. So that is why these diseases are a cause of concern. It's a belief. It's not fact. It's a belief that this is leading to people who are sitting in the offices, they should get the vaccine, and the people who are there in the ground force may not need it. But that is a myth, and that is totally a perception based thought. Because when it comes to influenza, in fact, since it's spread through aerosols, so in fact people who are there in the field are at a higher risk. And also when it comes to outbreaks, again another thought is that since it's often confused with common cough and cold, so it's like normal sardi khasi bukhar hai, sabko hota hai, ho jayega chala jayega. And people who are there in the offices are, they're a little more scared, so that's why they take the vaccine. So it's all very perception based, and only awareness and knowledge, and it has to be a top down approach when it comes to vaccination, and each one of your support, because this dialogue has to happen, that influenza vaccination is for all the at-risk category population, whoever is there, immaterial of the location, whether they're an HO based or an industry based. And pneumonia is such a huge complication, whether it comes for pneumococcal origin or for influenza complication as a secondary bacterial infection, that it can lead to life lost. And it's important, in fact, not just for the people, it's also important for their families to stay protected. So it's an awareness drive, and now government is actually making some initiatives in terms of introducing adult immunization. So as I am aware, that state of Maharashtra has started offering above 65 of years of age in terms of pneumococcal and influenza. HPV vaccine is being offered by the government of Punjab. And certain, right now a lot of discussions are happening. Association of Physicians of India have come out with a guideline for adult vaccination in India, for a reference document that can be used for answering questions as well as any kind of medical legal aspects when it comes to management of vaccination, which could be a common question among all. So it's a work in progress. Long way to go. Just the way universal immunization program is now 100% for children, I think in a couple of years we would see similar trends happening for adult vaccination. And the current pandemic, I think, is a huge boost, because all of us had to take the vaccine, and now the hesitancy would slightly go down. But wonderful question. Thank you, Dr. Kumar.
Thank you.
I think there are no more questions. Thank you, Dr. Ishika, once again. And,
I have one question, Dr.
Yeah, sure.
So, Dr. Ishika, this is Dr. Ramanjeet. As we all know, Indian government hospital respiratory OPDs are almost full, always full. And adult vaccination utilization is not so good. So what you feel, what are the factors which are leading to poor utilization? Is it, number one is lack of awareness, not among the general population, among doctors also? Or do you feel cost is the issue in country like India? Or availability is the issue? Or the lack of initiative by government hospitals or private hospitals? So what do you feel, what are the two major contributors to this poor utilization of adult vaccination?
Definitely, first first is the knowledge gap, even in the type of HCPs. It's not in the pen habit to offer viral vaccination at the moment. And secondly is the logistic support. So when it comes to pediatric vaccination, people have their cold storage in place and they're aware about how to inject the vaccine, how to manage the adverse events after that. But when it comes to the adult space, counseling, which becomes a very important part of vaccination process, a government hospital when dealing adults is like finish patients quickly. The and it's nobody to be blamed. The patient load is so high. So counseling needs to be done for the patients, because even if we've seen many times that uh, the vaccine has been prescribed, but the patient would come to say the doctor like lena padega kya, and the doctor is like le लीजिए अच्छा रहेगा. Then they leave because the further consultation does not happen, and the follow-up is not as much there. But it is a work in progress. As I said again, the awareness drive and logistic support and terms of counseling will actually break the chain when it comes to adult vaccination space.
But I believe
Cost is
India
not
is
much of a factor.
not. India is leading in terms of pediatric vaccination. In one of the leading
Absolutely.
country, we have a
Absolutely.
great chain, great system in place. So we
Absolutely.
can
And
utilize
that
the
chain can be utilized in
yes,
the adult space. Absolutely.
yes,
In the government hospital, that logistics is existing, but yet it is
existing.
not there in the mind that, same chain can be used for adult vaccination clinic.
See,
As
I
you
have
saw in
seen
the AIMS Jodhpur, yes,
yeah,
absolutely.
I have seen organized using the great awareness. Even I did for my organization, my last organization. Every vaccine was adult was free. We did awareness, but I feel there is a lack of initiative even by private hospitals in promoting adult vaccinations.
Absolutely. Absolutely. We're trying to proceed with protocols in place so that in the prescription itself, just the way we take names, sex, medicine name, prior history, etc., if just one line vaccination can be
Yes,
included,
yes.
and that will be like a immediate recorder, like if there's a vaccine required, that will be written in the
So,
prescription
so
itself.
we can say there is a need of raising awareness among medical fraternity as well.
Absolutely. Absolutely.
Thank you.
Thank you.
I think Dr. Sandeep Sharma wants to say something.
Yes, Dr. Ishika Das, ma'am. Actually, this adult vaccination program is in development and is, as you rightly said, still it is evolving, and still a lot of awareness need to be required, because we don't have a set protocol which vaccine to be taken, which should be given in which priority group, in which age group. So at Indian Oil, we have decided that before retirement, we will give a vaccination card to all the superannuating employees, and like when they are superannuating, at least whatever vaccines they are eligible to take, like influenza vaccine or some other vaccine, they will be given at that time, and later on they will be given a time schedule that at this age you take this vaccine, at this age you take like herpes zoster or any other vaccine booster dose if it is required. So these initiatives, they will definitely help, and these are a point of discussion also in various forums, in CII, in PICCI. So gradually government has to come out with some guidelines, and uh, if some solid guidelines are there from government, then it will definitely they will be helpful for the organizations also, because in ultimately you have to convince the patient, and if we are giving something to free to our patients from the organization, then we have to convince the management, yes, it is necessary. Like during COVID pandemic, when COVID vaccination started, people were reluctant to take influenza vaccine. They thought ki it is not required. Why to take two vaccines? So this awareness amongst patients, amongst doctors, amongst management. So this we have to take a lead. And as I told you that we have taken a lead in giving these necessary vaccines to our superannuating employees and giving them a card. Uh, at this age, you take this vaccine, don't forget it. Because ultimately, like for Indian Oil, every employee who joins is taken care till his death, even after post-retirement, to take care of their medical benefits. So it is our responsibility to take care of their immunization also.
Right.
It was a
This is
great.
a wonderful step. I think this is quite a good initiative
Yeah.
which can be replicated, because that is the at-risk population again when it comes to most disease burdens, whether we talking about pneumococcal or whether we're talking influenza. I think this is brilliant, Dr. Sandeep. I truly appreciate, and
Now,
I
when a
would
child
really
is,
take you as an example in the next sessions from now on, that
yeah,
Indian Oil has done that.
when a child is born, we give a vaccination card to the parents. These are the vaccines we have to take. So same we have to follow for our senior adults also.
Absolutely. Absolutely. Wonderful initiative.
If
Truly
organizations can take this initiative, at least for minimum vaccines which are mandatory, which are easily available, they are cheap, they can be at least given.
Absolutely. So even in the industry, when it comes to mass vaccinations, the costs are highly negotiable
Yeah.
in that space. Yes. Right. Thank you so much.
Thank you.
Thank you. I think we have concluded this session well within the time, and nice conversation. So I hand over the forum to our Dr. Ramanjeet Singh, who is the chairman for the next session. Dr. Ramanjeet, please take over.
Thank you, Dr. Shiraniket. Well, it's always special to chair sessions which are very insightful, very informative, like our last session taken by Dr. Ishika. I believe the next session will be equally informative, equally insightful, because it is again on the emerging medical technologies, which we all need to know, although we are medical fraternity, but still we need to learn more about it. So I hope it will be enlightening for all of us. The next topic is on stem cells and hematological cancers. And it's my pleasure to introduce our speaker, Dr. Amrita Ramaswamy. Presently, she is consultant hemato-oncology and stem cell transplantation at Artemis Hospital. She'll be covering facts and myths of lymphomas also. Dr. Amrita has worked as assistant professor in Department of Medicine, Pondicherry. She has also worked as senior registrar in Department of Clinical Hematology, CMC, Vellore. She has worked as associate consultant and later as consultant in hemato-oncology in Medanta Hospital in 2021 mid. So she has a vast experience in diagnosis and treatment of benign and malignant hematological disorders like aplastic anemia, thalassemia, acute leukemias, and multiple myelomas. So it will be great to listen from a doctor who is having a great experience in hematological disorders and cancers. And she'll be touching, I believe, few aspects related to stem cells, facts and myths of lymphoma, which are very much prevalent in our community. So with this, it's my pleasure. I welcome Dr. Amrita Ramaswamy. Doctor, please, ma'am, please.
Okay, thank you very much, Dr. Ramanjeet, for your kind introduction. And I would say big words. I am relatively experienced in hematology, but I think there are miles and miles to go. My topic was actually lymphomas, facts and myths. But then if there are any questions related to stem cells or stem cell transplantation, I think we can have a very interactive discussion regarding that also. I thank the organizers for giving me this opportunity, and without much further ado, on a Sunday afternoon, I think I should start. And let me just share screen.
Yeah, please do it. It's visible, doctor. Yeah, now it's full screen.
Thank you so much once again. So my topic was kind of facts and myths about lymphomas. So let's talk about facts first, and then as we go along, we can discuss the various myths that are probably associated with lymphomas. Now I'll be covering my topic. I won't be going into too much detail about the biology and the classification, because I think having a clinical perspective is very much important when to refer to a hematologist, because ultimately these patients end up with us for treatment. And what are the how do we investigate? Do we do a lymph node biopsy or do we do an FNAC? What are the staging investigations, and what are the myths that are associated with lymphomas? Now, Just a brief overview, all of us know how cancer develops. We know that normal cells, they are programmed to multiply and die. Live a span and then die when they become old. So there are growth signals and there are also death signals. So when there is a mismatch, when there is an excessive growth signal, when there is actually no need for growth, or when there is no death signal, when a cell is actually supposed to die, so cells kind of become immortalized and they multiply uncontrollably, and that's how cancer develops. Now, so growth, when there are no growth signals, and growth despite stop signals are what kind of characterize the development of cancer. And cancer also has got particular characteristics. It locally invades, and it has also got the ability to spread to distant sites, which is called metastasis. Now, coming to hematopoietic malignancies, so there is this kind of confusion about, is this a lymphoma or is this a leukemia? So what I would like to kind of clarify is, we all blood cells are produced in the bone marrow, and we have lymphocytes, and basically based on the origin of the malignancy, you can either have a lymphoma or you can have a leukemia. Leukemia is like a liquid component. So leukemia also arises from lymphocytes. But then if the clinical presentation is in the blood, is in the bone marrow, we call it a leukemia. Whereas in a lymphoma, the abnormal or the malignant lymphocytes, they kind of stay localized in lymph nodes, and the patient presents with generalized lymphadenopathy, or involvement of lymphoid organs. They can come to us with hepatomegaly, they can come to us with splenomegaly. But then we need to understand that these, even in leukemia, all the leukemic cells, they kind of pass through the lymph nodes, they go to the bone marrow, they are there in the spleen. So the differentiation between lymphoma and leukemia is more clinical. When somebody presents with regional lymph node enlargement or generalized lymphadenopathy, we kind of label it a lymphoma. Whereas if somebody presents with cancer cells in the blood and involvement of the bone marrow, we call it a leukemia. And leukemia can either be of a lymphoid origin or it can be of a myeloid origin, whereas lymphomas, they arise only from lymphocytes, from lymphoid precursors. And based on whether they arise from a B lymphoid precursor, we have B cell lymphomas, and based on if they arise from a T cell precursor, we call it a T cell lymphoma. So I think we've covered this, and so now what's the lymphatic system? So basically the lymphatic system, all of us know it has various lymphoid organs. We have lymph nodes which drain various parts of the body, and we also have the tonsils, the Waldeyr's ring, the spleen, the liver, and the bone marrow. And we have lymph nodes located throughout the body. All these lymph nodes and these organs have collections of lymphocytes. Apart from that, we have collections of lymphocytes in virtually every organ in the body. We have Peyer's patches in the intestine. We have mucosa associated lymphoid tissue, otherwise called MALT, which can be basically present in any system of the body which has got a mucosal lining. So, and the lymphatic system consists of B and T lymphocytes. And this is basically a structure of the lymph node in which we have blood which is flowing into the lymph node. And then there is a system of sinuses through which the blood is basically filtered. And during this passage through the lymph node, the various antigens in the blood are kind of exposed to B and T lymphocytes. And because of which the B and the T lymphocytes, in the presence of an infection or a pathogen, they undergo expansion and they produce lymph node enlargement. And this is how antigen stimulation takes place, the secondary immune response takes place, and this is how basically the body reacts to any infection. And then after passing through these sinuses, the blood kind of leaves the lymph node through the vein in the hilum. Now we have lymph nodes virtually almost everywhere in the body. So we have cervical lymph nodes, and then we have supraclavicular lymph nodes, axillary lymph nodes, and I don't think I should be, we have a very august audience here. And so we have lymph nodes basically located in various regions of the body. And unlike solid cancers, which can produce localized lymph node enlargement, like if somebody has got stomach cancer, so the perigastric nodes are the ones that are going to be involved first, and then probably later the other abdominal nodes, the para-aortic nodes, and then finally we have the supraclavicular lymph nodes, because this is like kind of the main node which is involved both in solid malignancies and also involved in lymphomas. In lymphomas, it's kind of a generalized lymphadenopathy that we are dealing with. Multiple lymph node regions are involved. But then when the lymphoma is localized, like in early stage Hodgkin's lymphoma, where the spread is from one region to another region or contiguous spread, you can have lymph node enlargement in just one particular region of the body. But generally speaking, lymphomas tend to involve multiple lymph nodes simultaneously, especially non-Hodgkin's lymphoma. Hodgkin's lymphoma spreads in a more orderly or in a contiguous fashion, in which one group of lymph nodes is first involved and then the other groups of lymph nodes are sequentially involved. Now we have bone marrow stem cells, and then we have the pluripotent or the totipotent stem cells, from which we have the myeloid stem cells and the lymphoid stem cells. The myeloid cells are the ones that differentiate into the mature blood components, all other cells except lymphocytes. Whereas the lymphoid stem cells, they kind of mature into three types of lymphocytes: T lymphocytes, B lymphocytes, and the natural killer cells. Now, T lymphocytes, we all of us know that it is responsible for cellular immunity, and B lymphocytes for humoral immunity. So T lymphocyte cellular immunity is kind of active against intracellular pathogens, and this is what also is important in cancer surveillance, because the T lymphocytes are the ones that kind of recognize tumor antigens which are present on cancer cells. B lymphocytes are responsible for defenses against bacteria. And I think I'll skip all this. Now coming to this part of the diagram, which I would like to kind of focus. So we basically have a T lymphoid progenitor and we have a B lymphoid progenitor. From the T lymphoid progenitor, we have the T lymphocytes, and from these cells we can have, if it is from a very early precursor, we can have a T cell acute lymphoblastic leukemia. The early precursors are called lymphoblasts, and they can either be B lymphoblasts or T lymphoblasts. So if we have a cancer which is occurring in a very early precursor, we call it a lymphoblast or a T lymphoblastic leukemia. Likewise, we can also have a B lymphoblastic leukemia. Then once the cells kind of mature and we have naive B lymphocytes, they kind of migrate to the lymph nodes, and in the germinal center, on exposure to various antigens, they kind of proliferate and differentiate. So the mature cells are the plasma cells. Malignancy of the plasma cells is called multiple myeloma, and from the germinal center, we have various lymphomas which arise, like follicular lymphoma, Hodgkin's lymphoma, diffuse large B-cell lymphoma. And from the naive B-cell, we have another indolent malignancy, which is chronic lymphocytic leukemia. I think this is the same thing which is in a diagram. So I'll skip this slide again. So from the naive B-cell, we have CLL. From a very early B-cell precursor, we have acute lymphoblastic leukemia. From the germinal center, we have follicular lymphoma, Hodgkin lymphoma, and DLBCL. And from the mature plasma cells, we have multiple myeloma. Now, we have various classifications for lymphoma. I won't be focusing much on the pathological classification, but a clinical classification will kind of tell us on how to react when somebody comes to us with a diagnosis of lymphoma. So clinically, lymphomas are either classified into high-grade lymphomas or low-grade lymphomas. High-grade lymphomas are the aggressive lymphomas, but the simple reason that they are aggressive makes them more amenable to chemotherapy. Chemotherapy drugs act better on aggressive lymphomas, and these lymphomas can be cured. Whereas indolent lymphomas, because the growth fraction in the lymphoma is very small, they tend to divide very slowly, and chemotherapy drugs are not nearly very effective in these drugs. And because of this biological character, they tend to be incurable. the disease tends to relapse multiple times, but at each relapse, we can kind of give some kind of treatment and improve the quality of life and, prolong the duration of life of the patient. But indolent lymphomas, as a rule, they tend to be incurable. They are associated with multiple relapses. Whereas the aggressive lymphomas, they are high-grade lymphomas, and these tend to be cured with chemotherapy, irrespective of the stage, be it stage 4 or stage 3 or stage 2. In between, we have something called an intermediate lymphoma, which I have not shown on my slide. In this category, we have basically mantle cell lymphoma, which has both characters. It kind of is indolent, but also aggressive. So this I've already covered. Now coming to 3 common lymphomas. So all these are B-cell lymphomas, and follicular lymphoma is the commonest encountered low-grade, incurable, indolent lymphoma. Diffuse large B-cell lymphoma is the prototypical aggressive high-grade B-cell lymphoma, and Hodgkin's lymphoma is a separate category in itself. These two are non-Hodgkin's lymphomas, and then we have Hodgkin's lymphomas. So another way of looking at lymphoma classification is Hodgkin's and non-Hodgkin's. And in the non-Hodgkin's, we have the aggressive, the indolent, and the intermediate category of lymphomas. Now the advantage of, I wouldn't say the advantage, the specific feature about having an indolent or a slow growing lymphoma is that sometimes the patient actually does not need treatment. Patient can actually have a long period of wait and watch when the disease is actually present in the body, but then the patient does not have any ill effects from the disease, does not have any manifestations because of the disease. It is sometimes people just walk in with a CBC report or in which the WBC count is elevated, and then you do a flow cytometry test and then find out it is CLL. Patient does not have any other symptoms. So in such situations, in indolent lymphomas, we do not actually treat. We put the patient on a period of observation or wait and watch. And once symptoms from the disease start developing, that is when we intervene to actually treat the disease. So follicular lymphoma is the most common indolent lymphoma, indolent B-cell lymphoma, indolent NHL. And we usually defer treatment if the patient is asymptomatic. And once patient becomes symptomatic, we have various chemotherapy options, but sometimes indolent lymphomas can also transform into aggressive lymphomas, and that's a very bad prognostic sign. Indolent lymphomas, when they transform into aggressive lymphomas, most of them, they need chemotherapy and probably even a stem cell transplantation. Now, coming to diffuse large B-cell lymphoma, which is the most aggressive, it's an aggressive high-grade B NHL. It is usually symptomatic. Patients usually come with symptoms either from pressure symptoms, or they have generalized lymphadenopathy, large bulky lymph nodes, extranodal involvement. They can have extranodal masses. They can have a stomach mass. They can have anywhere masses which kind of produce pressure symptoms. So these, there is no period of wait and watch in diffuse large B-cell lymphoma. We offer treatment to most patients irrespective of stage. And because it's a high-grade lymphoma, it is curable. Now, coming to just mechanisms of lymphomagenesis. So a common question when you are a practicing oncologist or a practicing hematologist is, why did I get this disease? So is there a particular reason why lymphoma develops? Accurately speaking, there is no one particular reason why a lymphoma develops. But then in certain subcategories or certain types of lymphoma, we have triggers. Like, for example, we have something, a gastric malt lymphoma, mucosa-associated lymphoid tissue, which has been linked to Helicobacter pylori. So chronic antigenic stimulation because of an underlying infection kind of makes the lymphocytes proliferate. And when they proliferate, they acquire mutations and then they become lymphomas. So infection is sometimes one of the factors which may kind of lead one to develop a lymphoma, and the mechanism is through chronic antigen stimulation. Then obviously immunosuppression from any cause If a patient is on immunosuppressants, like post-transplant patients, they have something like a post-transplant lymphoproliferative disorder which can develop. HIV, which is acquired immunosuppression. HIV is also associated with the development of lymphomas like DLBCL, and certain primary immunodeficiency syndromes which are seen in children, that also kind of predisposes people to develop lymphomas. Immunosuppression, just because your T lymphocytes, which are responsible for tumor surveillance, which are responsible for cancer surveillance, because they're not functioning properly, in this setting of impaired immunity or immunosuppression, lymphomas can develop. So we've covered this. Again, immunosuppression, immunodeficiency is a factor. Connective tissue disease like rheumatoid arthritis, Sjogren's syndrome, these are all conditions in which they are predisposed to develop a lymphoma. There is no strict family history. Infectious agents, some infectious agents like Epstein-Barr virus, HIV, all these predispose somebody to develop a lymphoma, and ionizing radiation can also lead to lymphoma, as we have in the nuclear bombs in Japan, where the incidence of Hodgkin's disease and other malignancies were elevated. Now coming to clinical manifestations, so patients can just walk in, like in CLL, chronic lymphocytic leukemia, they'll just come and tell you, I underwent a pre-employment health checkup, the WBC count is high, and the doctor is telling me I'm having CLL. So you can have an absolutely asymptomatic patient to somebody who is extremely ill, possibly having even tumor lysis syndrome. And the time course, it can be, a very slow time course. Like in Hodgkin's lymphoma, we all the while see patients who had a lymph node in one region of the body. They were there for 1 year, and then after 2 years, they come to us with some B symptoms like fever and night sweats. So fever and night sweats is something which is seen in advanced lymphoma, and it is also commonly seen in Hodgkin's lymphoma. So systemic manifestations, you can have fever, night sweats, patient can have weight loss, significant weight loss. Pruritus is something which is seen in Hodgkin's lymphoma, very characteristic. And anorexia, loss of appetite and wasting can be there. And obviously lymph node swellings are invariably present in most lymphomas. And when we clinically examine these patients, splenomegaly can also be there. And because of lymph node swelling, suppose we have abdominal lymph nodes and no peripheral lymph nodes, no palpable lymph nodes, these lymph nodes can cause pressure symptoms, they can cause obstructive uropathy. Patients can come to us with kidney failure also, because there are lymph nodes which are compressing on the ureters and causing obstructive uropathy. So basically any tissue and any manifestation is possible in lymphoma. Sometimes CNS involvement also does happen. People come to you with a low hemoglobin, with autoimmune hemolytic anemia, with immune thrombocytopenia. And as I said, compression of structures. Sometimes people come to you with paralysis, with paraparesis also, and obstructive uropathy. Sometimes people come to us with ascites and pleural and pericardial effusions. Now, staging. So this kind of tells us that, if a single isolated lymph node region is involved, it becomes stage 1. When we have lymph nodes, 2 groups which are involved on the same side of the diaphragm, it becomes stage 2. When we have lymph node structures involved on both sides of the diaphragm, it becomes stage 3. When we have involvement of the bone marrow and liver and extensive lymphadenopathy, it becomes stage 4. So diagnosis. Now we kind of know what are the clinical manifestations are. Now coming to diagnosis, when somebody comes to us with a lymph node, a lot of physicians, they kind of go in for an FNAC. An FNAC is not good enough to diagnose lymphoma. What we need is, if there is a palpable lymph node, we have to completely excise the lymph node wherever possible. An open biopsy is what is preferred. A core needle biopsy may be done if a patient has got an inaccessible lymph node, like abdominal lymph nodes, in which you cannot take out the lymph node completely. FNAC can be an initial kind of, you're not sure whether it is tuberculosis, you're not sure if it is lymphoma. So by doing an FNAC, we can kind of see maybe acid-fast bacilli or look at granulomas, or it will probably tell you there are atypical lymphoid cells. But then for us to make out the distortion of the lymph node architecture, we need an open biopsy or an excisional lymph node biopsy. Staging studies, once we have diagnosed based on the lymph node biopsy, once the pathologist has told us it's a lymphoma, staging studies usually involve a whole body PET CT scan to accurately stage the disease. And we do a bone marrow aspiration and biopsy in most lymphomas. In Hodgkin's lymphoma, this can be avoided if the PET shows uptake. But then bone marrow aspiration and biopsy is done by most hematologists, irrespective of whether it's Hodgkin's or non-Hodgkin's. Spinal fluid analysis and magnetic resonance imaging of the brain and spine may be done in case patient has symptoms of paraparesis or any CNS symptoms. And it is indicated in certain lymphomas which have a very high likelihood of involving the central nervous system, like a Burkitt's lymphoma, but it is not routinely done in all patients because to have CNS involvement at initial presentation is kind of rare, but it can be seen in certain aggressive lymphomas. So based on the type of lymphoma and the symptoms of the patient, we kind of decide whether we want to image the central nervous system and do a spinal fluid analysis or not. Coming to treatment, as I've said, indolent lymphomas, you can have observation. And when we have decided that the patient needs to be treated, so the treatment options are, I would like to put radiation first, because radiation has a role only in localized disease, in localized lymphoma. Chemotherapy is what we offer, systemic chemotherapy, and we have various chemotherapy protocols. And bone marrow transplantation is not offered to all patients. It is seen only, we offer it only to relapsed and refractory lymphomas after getting the disease under control. Immunotherapy, basically we have drugs which are more kind of used in Hodgkin's lymphoma. We have drugs which kind of remove inhibitory signals from our immune system and help our own immune system in clearing the cancer. It can be used as a single agent, but most of the times it is also given on a chemotherapy backbone. So this is in broad treatment options that we have for lymphoma. I think I'll skip these slides in the interest of time. If I just need to say a practical way of looking at lymphoma, so we basically classify into Hodgkin's and non-Hodgkin's. And in the non-Hodgkin's lymphoma, we have the indolent, the aggressive, and the very aggressive. The very aggressive, we need to treat. The aggressive also we need to treat. But the indolent lymphomas, sometimes we can defer treatment if patient is asymptomatic. As I said, the indolent lymphomas are generally, they are not curable. Multiple lines of treatment we can give, but these are, as a rule, not curable. The aggressive lymphomas and the very aggressive are curable. I would not say in some, in most of the patients they are curable, but obviously these can also be relapsed and refractory. Hodgkin's lymphoma, it's curable in most, and obviously we have to treat. Only in indolent lymphomas we can consider a period of wait and watch. With this, I would just like to end, and I would like to, if there are any questions, I'm open to taking them.
Thank you. Thank you, Dr. Amrita, because our next session is similar in continuation to this session. So if you're okay, I think we can take questions together after the next session. It will be another short session. But it was very lucid. You made it very simple for understanding, insightful as well. And thank you, you took out time on this Sunday for us to make this event successful. This took me, while I was, Genome Pathophysiology was one of my favorite books in which I read all of this. And it was very, for me, I think the chemo is good for aggressive and the indolent are tough to treat, was the takeaway. I think that was a new learning for me. Thank you. With this, I would like to invite our next speaker. It is my pleasure to have our next speaker, Dr. Ranjit Sahu, who is an additional professor in Department of Medical Oncology, AIIMS. The topic for today for him is blood cancer diagnosis and treatment. Dr. Ranjit is currently working as associate professor at the prestigious AIIMS, New Delhi. Since 2009, he's active involved into cellular therapy in the hematological malignancies, which is the emerging technology. He has done a good number of research areas. He has bone marrow transplantation is one of the area, multiple myeloma, acute myeloid leukemia, allogenic and autologous stem cell transplantation. So with this great experience, a great academic research experience, it's our pleasure and I welcome Dr. Ranjit Sahu with us to start this session. Welcome, sir.
Yeah. Thank you, Dr. Ramanjit, for that kind introduction. And Dr. Amrita for the previous presentation. It was very nice and lucid. It had made my job a little more easy. So I would start with what is cancer. She had already told about it. But cancer, to a pathologist, it is either a carcinoma or a sarcoma or a leukemia or a lymphoma or a myeloma. So these are the various types of cancer that we see in our clinic. So blood cancer is basically three types: leukemia, lymphoma, and myeloma. Out of which leukemia and lymphoma could be seen in both children and adults. Myeloma is seen only in adults. So these two things, I mean, leukemia, lymphoma, myeloma, they are all considered as blood cancers. Now, across India, when you look into all the cancers, especially the blood cancer, it is close to 10% of all the cancers. And whatever data or information we have, the blood cancers in India is per year is over 1 lakh. So it is quite a bit of a burden. Now, let's come to what is leukemia? Leukemia is actually, I mean, if you take it literally, leukemia is called as the blood cancer. Lymphoma is a lymph nodal problem. So technically, blood cancer means leukemia. So leukemia could be either acute, which comes in a span of few weeks or maybe a month or two. It could be a chronic leukemia. I mean, if you look into the Indian literature, it is the chronic myeloid leukemia, which is the most common type of leukemia. So it could either be a myeloid leukemia or a lymphoid leukemia. So myeloid is in your when you do a CBC, you got both neutrophils, lymphocyte, eosinophils, basophils. Out of which lymphocyte is lymphoid, rest everything is myeloid. So in chronic myeloid leukemia, which is the most common leukemia seen across India, it mainly presents with an increased number of WBC white cell production. The same with acute myeloid leukemia. They predominantly present with high WBC, but at times the WBC count could be normal or even low in number. The West and the Indian, I mean, they vary with the way the incidence happens. In West, the most common cancer is chronic lymphoid leukemia, and in India, it is chronic myeloid. Now, we are definitely not very different than what is happening in the West. It is because of the population structure. In India, when you look into how many patients are in the cancer-prone age group, now cancer is a problem which happens in older age. Older age means those who are 60 or 65 or above. When you look into our Indian population, 60 years or above is only 9% or 8 to 9%, let's say, which is very high in the West. So the cancer happening population in India, it is rare. So in the common age group, we do not have a lot of population. In the less common population age group, that is less than 60, we see most of the cancers. So we see acute myeloid leukemia, which happens at somewhere around 6th or 7th decade in the West, be it US or UK. It will come down somewhere around the mid 30s or early 40s in India. Chronic myeloid leukemia, which happens in the 5th or 6th decade in the West, we see it at an age group of somewhere around 30s or 40s in India. The same thing with CLL. The CLL, the age group in the West is in the 6th or 7th decade. In India, it is a decade earlier. So what happens in India, this sort of cancers, they happen in much younger population. And this is in many of other countries, many other LMIC countries, where the older age group, the population is not, when it is less than 10% or so. So lymphoma had been already enlisted by my previous speaker. So it is either a Hodgkin lymphoma or a non-Hodgkin lymphoma. And the non-Hodgkin lymphoma could be a low-grade or a high-grade lymphoma. I won't go into detail. What are the symptoms or signs? So leukemia, they will present with bone marrow failures. And because they take care of all these production of immune cells, especially the lymphocytes and some other cells, so it may be associated with infections. So quite often, a patient might present to you with infection and you find out that it is much more than that. The underlying cause is a blood cancer. In bone marrow failure, they predominantly present with anemia or anemia-related symptoms. Lymphoma, it could be either presenting, the classical way of presentation of lymphoma is presentation with nodal swellings, either in the cervical or the axillary, at times the abdominal, or it could be extranodal, when you cannot see any nodal presentation and it is maybe presenting in the stomach. These patients are initially confused with carcinoma, or in the brain, at times in the testes. But whatever it is, the symptoms and signs are pretty much, they are peculiar. And on a general clinical examination, you might be able to comprehend something about it. How do we diagnose these cancers? So first is clinical suspicion. Now, age group, I have already told you, cancer is a problem of older age. But in India, you have to be a little more smarter, because cancer could be seen in the younger age groups as well, because India is a young country. The clinical features are peculiar when they are carefully examined. And because these are not very common things to have in younger patients, so at times it could take a while to diagnose them. Now, what are the investigations to tell you that it could be a blood cancer? The first and foremost investigation in such cases is a complete blood count and a peripheral smear. Now, many of these labs as of today, they are giving peripheral smear by default. But then, if you are clinically suspecting these cases, you could actually call up the lab and tell them that we are suspecting that it could be leukemia, a blood cancer. Could there be a possibility in this case? When it is not clear with the CBC or the peripheral smear, you need to resort to some other tests. But most of the time, you will get the hint in the CBC. The hemoglobin could be low, the TLC could be low or high. The hemoglobin at times it could be very high, as in polycythemia vera. The platelet counts, they could be low, they could be normal, at times they could be very high. So a peripheral smear in such cases, doing just a peripheral slide, you could identify most of the blood cancer. The requirement of bone marrow could be required in somewhere around 15 to 20% of the cases, but in the rest 75 to even 85% of cases, you could manage them with only CBC and peripheral smear. The other routine investigations like liver function and renal function, at times you could see it in the biochemistry, what is happening. When a patient presents with a heavy burden disease, you could find there is elevation of uric acid, there is decreased calcium or increased phosphate, which is called as tumor lysis syndrome. The tumor tends to lyse and it is cleared by the kidneys to an extent, and the blood uric acids might increase. That might give you a hint. The alkaline phosphatase, the SGOT, SGPTs, the bilirubin, when there is a nodal mass which is there in the abdomen, these patients might actually present with jaundice. Bone marrow, it can be done with other ancillary tests like flow cytometry. In cases of lymphoma, you are more inclined to do a tissue diagnosis, which is obtained by doing an excisional biopsy of a lymph node. In patients where the nodes are pretty much, they are not non-matted, small yet enlarged nodes, they can be taken care by a tissue diagnosis. But even in lymphoma, when you are suspecting that it could be lymphoma and there is an enlarged lymph node, the first test to offer is a CBC and a peripheral smear. At times, this leukemia, they might present as lymphoma-like presentation, like ALLs, TALLs especially. They might present with nodal swelling, but when you do a CBC, you will find that the CBC is abnormal. The hemoglobin is low, the white cell is high, the platelet is low. In those patients, you could avoid a lymph node biopsy. So whatever it is, when you are suspecting a blood cancer, the first and foremost thing to offer is a complete blood count and a peripheral smear. Now let's come to its treatment. Now, the most common way these patients are treated with chemotherapy. At times when there is a diagnosis like chronic myeloid leukemia, which is a common cancer in India, we don't require any sort of chemotherapy. These patients can live as well with targeted therapy like imatinib. This drug is a very common drug and it is available at across India. Then immunotherapy. Now, this is the era of immunotherapy. Now, immunotherapy we had been doing sparingly in past, but now possibly we use immunotherapy in combination with chemotherapy at times as alone. Radiation. Radiation is a very important modality as narrated by my previous speaker. And it is mainly useful in patients with lymphoma. At times when the lymphoma is a low-grade type and localized, radiation could be curative in some of these cases with lot less toxicities from as compared to the chemotherapy. Now let's come to bone marrow transplantation. Now bone marrow transplantation is not required in everyone, but when it is an acute leukemia, especially when it is an acute myeloid leukemia, it could be reasonably used to a larger extent because these patients because AML, they present at the mid-30s in India. And apart from those patients who are exceptionally good risk, bone marrow transplantation could be required in quite a few. Autologous the bone marrow transplantation, it could be an autologous or an allogeneic lymphoma. And right now, we don't call it as bone marrow transplantation because in the late 70s or 80s, when this procedure had started, we initially took out those stem cells from the bone marrow because that is where the stem cells could be found. Now there are enough technologies to push the to push the stem cells from bone marrow to the peripheral blood. It is called as an injection that many of you could have used in your clinical practice, which is called the growth factors. When you inject growth factors to these patients, they are stem cells from the bone marrow, they will come into the peripheral circulation. And you just do a blood donation procedure like that through a machine called as an apheresis machine. And you could get down the peripheral, the stem cells. Now these stem cells can be even better than the stem cells which are obtained from the bone marrow. In allogenic, you tend to find a donor for a patient, especially the indication for allogenic is mainly acute leukemias. And these patients, they require donors, which we initially first look into the siblings. We tend to match it by something called as HLA test, which is pretty much available in all the labs. We tend to prefer those patients who have got an HLA matched sibling. And when we do not find an HLA matched sibling, then it is a difficult situation. Now, a bone marrow transplantation can be done in such situation when you don't have an HLA match, because as of today, everyone has a donor. But the type of BMT that you are doing in these patients could differ. could be different. I mean, it could either be from a matched sibling donor, or it could be from another family donor, who could be the father, the mother, other siblings which are not HLA matched, even from the daughters or the sons. They are called the haploidentical donors because, or the mismatched donors, where the HLA is not completely matched. They are either half or a little more than half matched, but they are called as haploidentical match. The other way of finding an allogenic donor is finding it from the many registries. Now there are many stem cell registries, even within India, across the world, where you could share the HLA report of the patient and you could find an HLA matched donor who is not a sibling, but yes, they could be a full HLA matched donors. They could be almost as good as a matched sibling donor or a haploidentical donor, but the complication rates of be it haploidentical or a matched unrelated donor, it is more. So more importantly, the cost of therapy, it increases drastically when it is not an HLA matched donor, which is a sibling. So if I may conclude my talk, so clinical suspicion is very important, and then the investigations, what you do, you should be looking into it pretty carefully. Blood cancers are curable problems with modern age treatment across all the age groups. But younger the patient, more curable it becomes. And some blood cancers like lymphoma, as enumerated by the previous speaker, like diffuse large B-cell lymphoma, when they're cured, they are cured. They live as good as a normal healthy donor of his age. And early referral of such patients is key, especially in acute leukemias or high-grade lymphomas. It becomes very important to refer these patients appropriately. And that would be my last word. I'll be happy to answer a few questions if we have.
We will take questions. Thank you. Thank you, Dr. Sahu. We will take questions. Thank you, first of all, for taking out time on Sunday. Looks like you are still practicing. You are on duty.
No, I'm not on duty. Yeah.
Okay, fine. Thank you. Sir, I think cancers are increasing at a great pace. So a diagnosis by a primary physician plays a great role. And you have touched what book says and what practical aspects are. You have mixed those things. So it makes it a great intuitive and thoughtful session. So presentation and catching it early in an Indian scenario, which is different from what is the Western scenario and what book says, makes it little more complex, I feel.
Yeah.
Because what we read is what we are getting from the books. But what practice says, it usually sometimes it is different. And you have touched it very much rightly. And for me, I mean, injecting growth factors, immunotherapy was I believe is a new advancement which is increasing. It was a great takeaway. Yeah. With this, I think now we can take questions from both the speakers for hematological diseases, diagnosis, if any question related to stem cell therapy, other therapies, you all are welcome. Now we have question from Dr. Gajendra. So
I congratulate both
yes.
the speakers, Dr. Amrita and Dr. Ranjit, for such a wonderful talk. You have really simplified the subject, and you have really broken some of the myth even we were holding with us. Now my question is, any one of you can answer. It's very simple. About a decade ago, acute lymphoblastic leukemia, especially in children, used to be considered as a death warrant. So what is the situation now?
Dr. Amrita, please. Will you like to take the question?
So I think pediatric acute lymphoblastic leukemia, B acute lymphoblastic leukemia, to be very specific, because T acute lymphoblastic leukemia is again a bad disease to have. So pediatric B-ALL has got very high cure rates with conventional chemotherapy regimens that we use. And I would say 90 to 95% of these children are cured. But then I can never say 100%.
Okay. So that means there is a lot of improvement over this last 1 decade.
Absolutely.
well as risk management.
So,
Now, one question to Dr. Ranjit, to you. How you see the prevalence of cancer in our country, keeping in view the pollution level, whether it is air pollution, water pollution, soil pollution, noise pollution, light pollution, many pollutions. So is it increasing or is it stable, or what is your say on that?
so now there are many cancers which are actually related to the pollution. For air pollution, we see a direct link with lung cancer. So these cancers have a direct link with air pollution. Wow, water pollution, we got some link to some GI cancers like stomach cancers, esophagus cancers, as well as, more importantly, when you look into this Gangetic, the belt of River Ganga, then there is a lot of association with gallbladder cancer. So they are these cancers. Now, with respect to the blood cancers, like it is prevalent in some occupations, like those who are janitors. It has also found an association with fisheries. And in many countries, when this investigation were conducted, we have not analyzed that thing formally, but what is in literature is blood cancer, it has got an occupational connection as well. So there are some occupations, agriculture, fisheries, those who are janitors, and few more, they could be having a link to the blood cancers.
Right. Thank you.
Well, I believe we have no more hands raised. Let me check again, which means no more questions.
So basically, let me just draw this thing. I mean, pediatric cancers, I mean, especially the ALL, these are, I mean, when you look into some institutes like St. Jude or similar institutes, it is curable to an extent of 100%.
Oh.
It is curable to an extent of 100%. Now, it is not about just the institute. Okay. In Indians, these patients, they are not far different than, we are also humans, we are not animals, you know. But the exact impact of the primary healthcare and the referral, which is pretty much clear in the West, that impact is not shown, because that cannot be put in Excel to look into what is the impact of those patients. But when you look into the races, like those patients who belong to the black race, there could be a genetic thing. But yeah, those pediatric patients who come from black races, the outcome could not be that good. And it could be related to the biology, because more of the black patients, they have T type ALL. But their BALLs, they are curable to an extent of, I believe, which is 95%. Dr. Amrita is smiling, that is actually 100%. But the impact is because of the early referral and a foolproof system there. Right. In India, it is curable to an extent of 60 to 70%. Now, where are we losing? We are losing this 30 to 40% because of the referrals. When the patients are sicker, these medications, I mean, they cannot tolerate these medications that well.
Late referral, actually.
Yeah, so the impact of the health system, it reflects in institutions in the West, while the thing in India is not, I mean, we are improving from what it was 20 to 30% initially. Now it is 60 to 70%, but yeah, there is still a long way to go. And the exact importance will not come from an institute like, say, AIIMS or PGI or similar institutes. The impact will come from the primary health centers, from where the patients are shifted very quickly. They are referred very quickly to institutions who have experience in dealing such patients.
Right. Thank you.
So we don't have no more questions because the session itself was very lucid, simple, understandable, and informative.
Thank you.
Thank you, Dr. Ranjit Sahu. Thank you, Dr. Amrita. So with this, Dr. Ranjit Sahu was the last speaker of this 9th Global Conclave OCCUCLAVE 2022. With this, we can take this session forward towards a closing ceremony. We have 3 days of professional and academic excellence where a lot of speakers from national and international repute participated. So day one was, which was very lively event. I was there. It was a day of award ceremonies, a lot of orations from various organizations. Day two was having sessions from various speakers from international and national levels. But this 3 days of academic excellence in OCCUCLAVE 2022 was not possible without our partners. So I would like to give my sincere thanks to all our partners in this global endeavor. First of all, I would like to thank our title partner, Indian Oil Corporation, and our diamond partner, ONGC, which was very well supported by GAIL India, Oil India, and NHPC. I also want to give my deepest thanks to our knowledge partners, which are AstraZeneca, Medtronics, Abbott, Edwards Life Sciences, India Health Link, Convatec, and our international partners, University of Singapore and Mars Corporation. I'm thankful to all the attendees, speakers. With your participation, this type of events are not possible. This gives us boost and motivation to take such type of events at higher and higher level every year. So with this, now I look forward to take the next step towards the closing ceremony. And for this, first of all, I invite Dr. Ashish Vijay Jain, who is the Vice President and Head of Health and Wellbeing GlaxoSmithKline, to come forward and say some words towards the closing ceremony. Dr. Ashish Vijay Jain, please.
Thanks a lot, Dr. Amandeep. This is really wonderful. And I think the last 3 days have witnessed an academic feast. Not only we have seen quite a variety of sessions on workplace health based on the WHO Healthy Workplace model, but we have also seen some great clinical insights on different topics of interest. I think in the end, with the completion of these 3 days, it feels a lot of learnings have come across. It's time to now start reflecting and implementing many of these things into our practice. I really want to thank all of the speakers and the people who have made this a fair success. Thanks a lot to everyone. Can I now invite Dr. Sandeep to take it over, please?
Yeah, thank you, Dr. Ashish. Before I start, may I request Dr. Rajiv Kumar Jain, sir, our Senior Vice President of Association of Environment and Occupational Delhi, to give his concluding remarks. Dr. Rajiv Kumar Jain.
Well, it's been innovation and experience in its own right, because one day we had fully physical without and 2 days for almost 6 hours each day, 4 and 6 hours on Saturday and now Sunday. We had a galaxy of speakers on various clinical, administrative, and a mix of clinical and occupational health subjects, speakers speaking on a diverse way of actually promote occupational health in our organizations. But the beautiful experience has been because of the involvement of people from diverse backgrounds, and participation also has been very diverse. And I'm finding all through the presence of reasonable number of attendees and panelists. And I'm sure we will get a huge number of shares on views on YouTube channel when we upload the excellent academic content that has been shared in the last 3 days. That bodes well for a post-pandemic new normal. And this new normal shall continue for, I believe, for a reasonable number of years, not months, because of the uncertainty involved in post-pandemic situation. Even today, I've seen the highest death rate are continuing to be. And I believe we should accept to live with the reality, and we should have these kind of academic interactions through having global conclave on occupational environmental health in subsequent years in this kind of format. I compliment the entire team of AEOHD and our partners who have ensured that we have sufficient resources to take it forward successfully and bring out the best in the field of occupational and environmental medicine and sustainability without compromising on the aspect of safety. I really feel proud to be part of the group, and I again would like to thank all the members of AEOHD team and the partners and the speakers and the audience to have spared their valuable time for this global conclave. Thank you so much.
Thank you, Dr. Rajiv Kumar Jain sir. Now, Dr. Mrs. Kamala Patiala, our Senior Vice President of AEOHD.
Thank you, Dr. Sandeep. I think towards the closing today, as we look back during the post-COVID, we have assembled for 1 day physical and 2 day on the virtual platform. We have had number of topics other than COVID, which we could deliberate upon, and we could take a lot of learnings from here on the first day's orations and the 2 days virtual program wherein we had both national and international level speakers and number of doctors of vast experience who shared their presentations with us. It was a great learning. I thank everyone for the participation here, and I thank everyone from the AEOHD team as well as all the partners and the audience who have come and attended our sessions. And I thank everyone. Thank you very much.
Thank you, madam. Dr. Shiniket, would you like to say something? So before any other panelist wants to speak anything, may I just recollect that it was a great show, and yes, as Dr. Rajiv Jain sir has told, that in new norms, we have created a benchmark that we can organize a 3-day conference, 1 day totally physical with more than I think more than 175 participants who had physically participated, and whole day deliberations were there, and that was on WHO healthy workplace model, and that was a great learning for all the organizations that yes, we can do a lot through our various initiatives in our organization in the field of preventive and promotive health, taking care of leadership involvement, workers involvement, doing all the ethical work, doing no harm to our employees and to the surrounding community, and compile whatever we have done and do the advocacy for the WHO healthy workplace model. And I think AEOHD initiative or the AEOHD initiative, this will go a long way in creating healthy workplaces in different organizations, and I'm really grateful to everyone that you had all been witness for this great journey of at least 3 organizations from our members who are part of our AEOHD, like Hero Motocorps or GSK or Indian Oil Corporation. Those who have in series, they have won this Global Healthy Workplace Award from 2019, 20, 21. So gradually, if we all like handhold each other, in 22, 23, 24, we can, all our organizations, they are doing great things. And if we present our work in a very compact way, presentable way, then I don't think we can't win these awards. And these awards, they will definitely give us a global recognition, and it also gives recognition to our employees, to our workplaces. They also feel motivated, like Indian Oil. When we got the award, when our chairman felicitated us, he said it should not remain as a global, as a corporate award. It should go down to the location. So in this effort only, we are now promoting this WHO healthy workplace model, and this is an official model which has been declared by WHO, which will help in achieving the sustainability goals also. So since we are all working in different private and public sector undertakings, this will help us in creating healthy and happy workplaces. And moreover, clinical aspect, which was covered in next 2 days, and with the participation of learned speakers from different faculties, and international speakers from NUS or MAS. We got a lot of new things which we can imbibe in our respective organizations. Like NUS, they have told us that they can support us in carrying out EAP programs in our respective organization. So if we can get some skill training from these good learned speakers, then definitely this will help a lot in taking the things forward. This adult immunization, treatment of cancer, treatment of various cardiac new procedures. So we are facing day in, day out, we are facing these difficulties. Whom should we recommend? Whom we should not recommend? And as Dr. Sahu was there and Dr. Ramaswamy was there, they said early referrals of the patients and early decisions on the patient, they help us in increasing the cure rates of these patients and increasing the survival of these patients. And we can give right treatment to the right patient at the right time. So that is very important, and this is the only reason why we are calling all these faculties from different streams of medicine, because ultimately we as industrial physicians, we are not specialized in different clinical fields, but we should be aware of what is the latest thing which are going on in the field of medicine. And we have to be a family physician of all our employees, all our workers, and give them the best of what is available in the science. So I think, sir, this was a great show. And before we conclude, may I request our president, sir, to give the final concluding remarks, because it was his leadership only in which we have conducted this program, and we had been doing these academic workshops every week for last 2 years. And Dr. Rajiv Jain sir has been a great source of inspiration for every one of us, and we have devoted a lot of time. Even our family members, they say how much time you are devoting for all these activities. So it is our passion, and it is our zeal that yes, we want to spread the things to our fellow colleagues, and we don't keep everything to ourselves. We have got a DigiConnect webinar YouTube channel. If the things are not, people don't get time at the time of direct live relay, then they can revisit these YouTube channel and all these sessions. more than 175 sessions, they are now available. And we have got a huge bulk of sessions which we have recorded earlier, and soon they will be also uploaded. So, sir, we have created a great resource, great repository under your leadership. And I would like to have your concluding remarks, sir.
First of all, I would like to congratulate each one of you for conducting this 3-day conclave in such a wonderful fashion and with such a big participation of each one of us. So congratulations to all of you. It was a beautifully planned with very apt and relevant topics of interest, and there was a great participation from all of you. So I'm extremely happy and delighted on this concluding day of this 3 days event of our annual and global conclave. And I wish in future we will also continue to do such good work with our participation of all of you and other partners as well. So with these few words, I thank you all for this lovely program which we had for last 3 days. Thank you so much.
Thank you, President, sir. So before we say goodbye today, let me thank my own organization, Indian Oil Corporation, who have supported this event as a title partner, then ONGC, who have supported as a diamond partner, then other PSUs like NHPC, Oil India, GAIL India Limited, Petronet LNG, and our knowledge partners who have supported us. They have given us all the resources to conduct this great program. And last but not the least, we should thank our secretariat who have conducted all this program smoothly for last 3 days. We should thank Shivang and Ankur also, who has helped in projecting our work in a very descriptive way, in a nice way. And yes, we have created benchmark, and it will be good for everyone to continue this work and sustain this work in future. So with these remarks, we can conclude this 3-day conclave. Thank you very much, everyone, for participating in the program.
Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, Dr. Ashish, Dr. Ramanjit.
Thank you, sir.
Thank you, everybody.